All right. Well, let's get started. So one of the things we usually wait till the end of class to do, and so the students usually end up not getting done in an appropriate amount of time, is getting the National Registry stuff completed. So that way I can approve you to take your exam and your practical tests. So what I need you guys to do is go in to where it says log in or create an account here, and you're gonna go down here where it says create account. If you already have one, then just go ahead and log in. Some of you have taken this class before, might have already completed this, which is perfectly fine. So once you use password. There we go. So once you log in, you're going to create your account. And then you're going to go down here where it says create certification application.
Well, mine doesn't look anything like that.
You don't have that either? You don't see yours like that?
Oh, you're already in the, yeah, I'm still creating my account.
Yeah, I've had an account for a while.
Yeah, sorry.
I may look a little bit different because I have other instructor stuff that's on here too, but. So once you get in there, you guys will create a certificate application for the EMT level. And basically you'll go right down through all these here. And then I have to approve you for my class. For your CPR expiration date, our CPR class is October 1st. So put down 2 years from that date. So you put down October 1st of 2025.
I'm assuming it's okay that we're going to register with a different email than what we're using for the class.
That's fine.
Okay.
Yep, it's whatever you want to use for what you guys do there. I'll kind of go through all this stuff with you guys as we're doing it. Then we'll get started on patient assessment. And just let me know when all you guys get that completed.
So it's asking when we'll complete the EMT program.
So the EMT program completion is November 19th, 2023.
Can you say that again? Sorry, I wasn't paying attention.
It's the last day of class, November 19th, 2023.
1923.
Yeah, 11/19/23.
Hey, Kevin.
Hey.
It's Fred.
Hi, Fred.
I'm trying to recover my password, but this thing is giving me an error message.
Okay.
So I'm gonna try it again. See.
Yeah, it's if you can't get into it, that's fine. We'll figure it out. I know that you already have an account. It's just getting everybody else there, and then we can work on it. People that can't get in, you may actually have to contact the National Registry as well.
Yeah.
So you need to know once it's completed?
Yeah, let me know because I have to approve you for the class.
All right, well, mine says it's completed. The application's been completed.
All right, so
What are we? It says you're seeking to gain national certification. Please select the EMS professional role.
I haven't done this in a very long time.
It's not giving me, it's just giving me EMS professional. Is that what it would be? Because I'm not a
Yes.
program director. Okay.
Correct. Yeah.
All right.
What is the application fee? What is that initial application fee?
So there'll be an application fee you have to pay to test
Okay.
at that point, but we haven't gotten that far yet.
All right. I didn't know if it was something we should be doing now.
No, I'd wait. Just wait till you get to that point. Have all of you finished creating your account?
Yeah.
I did,
Has
and I'm
anyone
okay.
done the date of birth? Because I can't seem
Yeah.
to get a year in there. Like I can't type in.
You have to scroll. I had to scroll up to my
Yeah, I had to keep scrolling.
my year.
Mine's far away. I'm old.
Kevin, when I'm creating the application, when it says which of these is your EMT program, do I put NH50395 Kevin Romano?
Yes.
Okay.
You have to put, it's New Hampshire, my license number for EMS instruction and my name.
Okay.
Just make sure you check my name, not the other Kevins that are there.
I haven't gotten a chance to see any names. I created the account. Now I'm at a screen that has my name over to the left, and it says my account, personal profile, professional profile, payments. I don't see this right here.
Right. So once you have your dashboard,
Yeah.
then you want to create your certification application. Then you'll
Oh.
choose EMT.
Oh.
I'm not sure if it'll let me do it though or not.
And Jennifer, I'm way older than you, so I'm gonna really have to be scrolling.
Do we submit it when we're done?
Yeah, once you're all done.
Okay.
I'm a lot older than I look.
Yeah, you see the EMT program. That's going to be my class.
Another 40 years.
Certification. EMT. If you
So you're kind of watching what I'm doing here. Also, New Hampshire. And then which one of these is your program? You scroll till you see my name. Next. And then you'll go to next here and then submit. I'm not going to submit it because I'm obviously not applying for a class, but this card application for me. Then
At my senior year of high school.
just trying to find. So I have Jen, Kim, Colin, and Josh so far.
All right.
Oh, here we go. All right.
Yeah, so once you're in there, then once we get done, I can approve you.
So we got to do the create certification application. So that you
Correct,
said that was
yes.
all right. I finally found it. All right.
So once you go through all that, then your name will pop up here in this list that I have as far as current students. And then once we're ready, we'll go to the course completion verification here, and I'll go in as EMT. And then I can put down that you guys successfully completed it. And then once that happens, you guys can take your tests, your national exams. But let me know when you guys are done with that, and then we can start the lecture up. I just thought this is kind of important to get done sooner than later.
Okay. So Kevin, I've just completed the profile. Now where do I go? I'm sorry. What's that? Course completion verification.
Yeah, the course completion verification for sign. We go back to the candidate really quick for me.
Candidate, that's where I go?
Yeah, so underneath a candidate dashboard, if
Got
you
it.
scroll, you'll see create certification application.
Yep. Wait a minute, let's see. I'm at dashboard. So I hit EMT.
No, go down a little bit lower than that. Can you guys see my screen at all too, or no?
Yep, I can now. Okay.
Okay, right here.
Okay.
Create certification application.
Got
And then go through that.
Then
Where you get the
EMT.
program information, your CPR expiration date is going to be 10/1/2025. Everybody will have their CPR October 1st. That's when we're doing the class.
Okay, but do I pick my level first? Which level of certification am I choosing?
Yeah, so you're going for EMT.
Okay, and then I go to my CPR expiration. Okay.
Yep, and then program information will be NH, whatever my number is from there.
I can't seem to click onto the CPR. Let me try that again.
Well, you have to go through the steps. So click on EMT.
Yep. And then the
Um,
information above.
yeah,
Okay.
click on that button there, and then you'll see when does your CPR expire.
Gotcha. And I got the date
Yep.
of that. Okay.
Yep, 10/1/25. And then work your way from there and just keep going through it all.
All right, there we go.
We have 1, 2, 3, 4, 5. We're missing 2 more. But I
Yeah.
know, yeah, I know, Tina, you're finishing yours, and I know, Fred, you're going to get yours taken care of. You just got to figure out how to get yours to switch over.
What is the valid code for the CPR
Kevin, I
test?
got into
Oh,
mine.
it gives a date. Okay.
Yeah.
Alright.
Kevin, I was able to get the password changed.
Perfect. Perfect. It may already say that you have an application still there from your previous class too.
It does, yeah.
So you may have to contact the registry and have them swap it.
So Kevin, it says here that I can create a certification application. Is that what I want to do?
All right.
Hey, Kevin. You there?
I'm here. Apparently I hit mute by accident. Go ahead.
That's okay. So quick question. How long do you have to take your second attempt from the time the class ended?
Well, you have a total of 2 years.
Do you really?
Yeah, you do. And you get 3 attempts, and if you fail 3 times for the written, then you have to take a refresher class, and you get 3 more attempts after that. And if you fail after 6 attempts, then you have to do the whole class over again.
So the last date I took it for the first time was December of 2020. So that means I can take it again before December.
Well, it would have to be 2022 then. 2 years.
Oh yeah, that's right.
Yeah, so your class would have expired already.
You're not wrong. Okay. Okay.
I completed mine, Kevin.
Okay. Thank you. Trying to find something really quick before we do this, but
Kevin, sometime when you have a chance, I just need to go over immunizations with you.
yes. So I got an email from you. I'm going to go over that with you later on.
Okay.
Yeah.
I'm willing to
at-
try the Hep B again. But if I have an
at-
Okay.
adverse reaction, I can't.
No, then we'll do is we'll sign a waiver.
Okay.
I'm having a hard time getting mine from the army as well, so I don't know what I'm gonna do, but I'm working on it.
Okay, we'll figure it out when it comes time to that. If we have to sign waivers for certain things, we can.
Yeah.
I just
Thank
get
you.
declination and stuff like that you don't want to do take it.
Yep.
But then that may. It's not going to hurt you for getting on ride sites. If you were doing your
All right.
advanced EMT, it might hurt you getting into a clinical hospital site.
Good. All right. I was worried about that. I know I'm
Yeah.
current. I just can't. I was in the National Guard and I got out of the Guard in 2005. And Christ, I mean, my paperwork
it
somewhere
tighter.
down in Washington. What's
Just
that?
get
Right.
it tighter.
What is that? Like a test to see if you've had the shot or
Just a
something?
blood draw. Yeah, just a blood draw. And it'll
it's a
tell you
blood
what
draw.
Yeah,
I could do that. Yeah,
very
I need a
simple.
tetanus anyways. I need a tetanus, so maybe I'll do that. Thank you.
Yeah, all it is a blood draw, so not too bad.
Yeah, so I had my titer done and it showed no immunity for the Hep B, even though I had one shot.
Right. I'm just trying to get set up for the class now. Here.
So I can get off this on my Kindle, off the
Yep.
registry. I'm all done.
You're all set. Once you've done the class, the setup, you're good.
Okay. Hey Kevin, on Saturday, are we to wear uniform or street clothes? I mean,
For
on Sunday,
Sunday?
I'm sorry. Sunday.
So Sunday, street clothes are fine. Just make sure
Okay.
that everything's closed-toed shoes, all that kind of stuff. For practicals. For clinical days are a different story. Those are more uniform, but practical days you can wear jeans and a t-shirt, things like that's fine.
Okay.
And keep in mind you will be getting dirty, so
I'm a gardener.
all right. So let's talk about patient assessment. So one of this is kind of a lengthy lecture, and when I've been told before on previous classes I've done this lecture for, I kind of go a little too in depth, but that's not a bad thing. So I want to get you guys the most information. Patient assessment is the basis of what we do. And going from EMT, advanced EMT, paramedic, critical care, flight, doesn't really matter. We still do the basic level of assessment. And with that being said, we have to understand what the basics are. And the thing about EMS, we use acronyms and a lot of them. And the higher you go, the more acronyms you got to remember. So let's start with that. We'll start with that part there first. And we're going to kind of have a little bit of fun with this too. So let's go over past all these competencies that are here. We're going to cover all this stuff in depth. If I can save a few extra minutes, might not be a bad option here. So patient assessment, very important. What we do, we walk through the door. Everything starts from the dispatch of the call. And as we're responding to the call, listening to the updated information, going into approaching the house, getting out of the ambulance, knowing how many steps we walk up into the home, going through the door, look at the surroundings, keeping everything open. We need to look at what we're looking for. And then from there, we start going to our patient. We want to see what kind of condition they live in, what kind of lighting's inside the house. All this stuff plays a huge part of our assessment. And we'll pick up more of that as we go. Like, why is the room dark versus being light? You walk in, you have a stage 4 hoarder versus someone who has a really clean home, right? And you can tell a lot by what your patient conditions may be just by the living conditions that they have. That's part of our scene size up. And scene size up never stops. It always continues. It's a very liquid type situation. So EMTs must master the patient assessment process. And the way I'm going to teach you guys is going to be done through differential diagnosis. I want you guys to be clinicians. So patient assessment is used to some degree in every patient encounter, whether it be a patient refusal to a motor vehicle accident where the patient tells you, go pound sand, I don't even want to talk to you, right? We still do an assessment. We can still see if they're breathing. We can still see their airway is patent. We can still tell how their circulation is by looking at their skin color and temperature. There's a lot of things that we can do for an assessment that are visual, that do not require us to truly have hands-on. Obviously, I can't hit that button either now. I was just trying to bring up. So if you guys have any questions for some reason, I can't bring up the chat box. So just unmute and come right in. All right. All I can see is your cameras, but I can't see the chat box popping up on my screen for some reason. All right. So there are 5 main parts to a patient assessment. As far as 5 main, I should say 5 main parts to the assessment process. And we divide them into 5 sections. One is scene size up. The second would be primary assessment. Then we go to history taking, and I kind of like to call that interrogation. I like interrogating people, but I'm very persistent to get what I want. Then we go to our secondary assessment, then our reassessment. So the order in which these steps are performed depends on the patient's condition and the environment in which the patient is found. So what do we see when we come in, how the patient appears? Now, obviously, the patient's unresponsive and there's no family around or anybody around to tell us what's going on. History taking may not be the greatest thing for us because obviously they can't talk back to us, right? But we're not going to do a reassessment before we do a scene size up. But scene size up, like I said, is very liquid and we do it all the time. Things can change on an instant. So it may be necessary to change the order of some of these steps after the scene size up based on your findings and the need to prioritize the care of certain conditions that we come in contact with. So rarely does one sign or symptom show the patient's status or underlying problem. That's why I said we have to interrogate. We have to do assessment, hands-on, get vital signs, look at the big picture, look at their medications, look at their medical history. How does the patient actually feel? What you're dispatched to may not actually be the chief complaint. So you ask the patient, what's going on today? Why did you call EMS? Right? And they may tell you something different now than what happened before. Right? And we'll get more into the in-depth assessment here in a little bit. Two things you got to remember. Symptoms are what the patient tells you. Signs are what you can see, right? So a symptom is subjective. It's a subjective condition that the patient feels and tells you about. So if I were to ask Tina, since you're the only one on my screen right now, but I can see, Tina, do you have any chest pain today? You're going to tell me what?
I do not.
Okay, that's a symptom, right? If you said, yes, you do. Yes, I have chest pain. Yes, I have shortness of breath. That would be a symptom. A sign would be if I walk in and I see that Tina has pale, clammy, grayish, ashen skin. That to me would be a sign, right? So objective conditions that you can observe about the patient actually being there. If she is having a significant shortness of breath and she has her elbows on her knees and she's leaning forward, we call that tripod position. If we start noticing accessory muscle use, we start seeing pursed lip breathing. And we're going to get into pursed lip breathing and how that affects PEEP, positive and expiratory pressure, when we get into respiratory conditions. But those are signs, things that I can see versus what she will tell me, right? And now she did mention as well, and I know we're going a little ahead of things, but I want to kind of hit it now so when it comes back around again, she told me that she does not have chest pain. So that would be a pertinent negative. A pertinent negative, right? So it's a negative answer to a pertinent question that we did ask. And that's going to be important for documentation, especially when we talk about medical legal. So the scene size up refers to your evaluation of the conditions of which you will be operating, right? So that situational awareness we talked about before is necessary throughout the entire call to ensure safety. That's that liquid situation that we're currently in, right? So we need to make sure we're observing everything that we do, right? Just because you walked up 10 steps does not mean that they don't have an easy access in the back to the porch that goes around a grass walkway back to the ambulance where you can get a stretcher into the house, right? Or you're working in a triple decker and you go to a triple decker home, like say down in Boston or whatever, and you're working down that way and you have to go up 3 or 4 stories with no elevator. We're not going to bring a stretcher up there, but we're going to know before we go up, we're going to bring this, and this. First in bag, cardiac monitor, stair chair, oxygen, right? We're going to bring the stuff up that we need so we don't have to go back down 4 stories to be able to get the equipment that we need in the ambulance, right? Because we're not going to walk anybody. Patients with chest pain, shortness of breath, strokes, we're not going to tell them to walk down the stairs. It's going to cause more stress and cause a bigger problem. So we're going to have to stair chair them down the stairs, right? So we got to look at that whole entire situation and what are we going to bring into the house? What level are you and your partner at? You're both EMTs. Is one a medic? Do we need to call for ALS? That's all part of your situational awareness and what's going on based upon your dispatch. So dispatch will provide you the basic information about the request for the assistance that is needed. So let's say, medic 1, please respond to this location for a Delta level chest pain. Patient's a 56-year-old male complaining of chest pain with a previous heart attack. What are you thinking at this point in time?
Am I?
Yeah, possibly. Doesn't mean that it is, but it's in the back of your head underneath that differential diagnosis. And we can do other things to be able to determine whether it's an MI or not, right? So scene size up combines information that observes to help ensure safe and effective operations. We need to make sure that we are safe first. And if we're not safe, then we should not be going in. Scene safety is always going to be a priority. And one of the things you're going to have to memorize, and you should be saying all the time, are these two things: scene safety, BSI. Scene safety, body substance isolation. Scene safety, BSI. Right? That is going to be a critical fail on your practical stations if you do not walk into the room and say, when they say ready, go, scene safety, BSI. All right. An understanding of the situation and conditions prior to responding will help you. For one, if it's a frequent flyer that you go to constantly, you kind of have an idea of what you might be coming into. Again, don't become complacent, but you have an idea of previous calls that were there. The dispatcher information, what they give you. Patient was instructed by EMD to give, patient took 324 milligrams of PO aspirin. Patient's been advised not to have anything to drink and is currently sitting in the house waiting for your arrival. Patient is pale, cool, clammy, and diaphoretic. The information they can get through emergency medical dispatching, right? And then an observation of the scene when you pull in. Am I going to have to walk a mile and a half down the driveway because it's snowed in and we can't get in? Do we need to call for plow trucks to come in to help make access for us? These are all decisions you have to make upon your scene size up as you move through. So to ensure scene safety, you want to what issues that you may encounter in the pre-hospital setting can definitely range from minor difficulties to major dangers that we might find. So if the scene is not safe, and you and your team, for you and your team to enter the scene, then approach and manage the patient. Do what you can to make it safe or call for additional resources. And I'll talk about this here in a second with the scenario. Consider traffic safety issues as well and issues related to scene safety if you must approach a patient in a working roadway. So you respond to this is kind of basic knowledge stuff, it's common sense. Let's say you guys respond to the local auto body dealership and you have 5 patients unconscious on the floor. Would you go in?
No.
No.
Why? Why not? There's 5 patients unconscious. Why aren't you going to help them?
Yeah, but why are they unconscious?
Exactly.
Most likely environmental.
Yeah.
They could be. So I told you it was at a body shop. So what could have happened?
Gas leak. Some type of
Chemical.
Chemicals.
Yeah, hazardous material.
Yeah. Hazmat, chemicals, carbon monoxide. It could be anything. But things don't add up when you see 5 people unconscious on the floor. If you walk into a residence and you start getting a headache, you're going to stay inside the residence?
No.
No, time to get out. You start smelling that foul smell. It smells like propane, or for the firefighters room, mercaptan smell. You guys start smelling that. Do you stay in the residence or do you back out?
Back out.
Yeah, because the scene is not safe for EMS providers to be there, right? These things require SCBAs and appropriate intrinsically safe radios to have communications back and forth so we don't actually cause a spark and set off an explosion. And being a hazmat provider, then you know more about propane being heavier than air, specific gravity being heavier, so that it finds lower places to be. Again, training and education gets you to that point, right? So we have an understanding. And keep in mind that propane can still off-gas carbon monoxide, right? So having an understanding that the scene is safe or not, just because it doesn't appear to be anything, remember that carbon monoxide is colorless and odorless and you cannot taste it or smell it, right? So it has been a requirement for all New Hampshire anyways, that all first in bags are required to have a CO meter on them. So that way when you go into a residence and it activates, you back out, it's not safe. So, but I can see the patient 55 feet in front of me in the house. Doesn't matter. We don't go in, right? That's fire department with SCBAs. Now, if you're cross-trained and you have SCBAs in your ambulance, put them on and go in and pull the patient out. That's a different story. But for a lot of us, we just do EMS only with no fire background. Be safe. Consider traffic safety issues on the roadway. What just happened the other day, about maybe a couple weeks ago? I believe it was in Maine, right?
Yeah, we just had somebody die last week actually, right in town. They were tarring. They were doing tar.
Yep.
And
What about all
somebody
the state troopers just got hit in Maine?
I didn't hear about that.
I'm pretty sure it was Maine. It could have been New Hampshire, but I'm pretty sure it was Maine.
It
There were
was
three.
Maine.
It was Maine. Okay. 3 state troopers and a brand new cadet, if I remember correctly. Brand new.
Oh,
new
I
one.
do remember that. Yeah. Yep.
Yeah,
Okay.
wasn't it a 16-year-old texting?
Probably.
No, it was someone that was high.
It could have been 2. They could have been texting and high.
Could have been.
And it's
Not
possible
hard to take a
nowadays.
test to see if they're high.
But even still, state troopers, blue lights flashing everywhere, bright as hell, and they still got hit. So be safe. Be safe on the roadways. Park yourselves in situations where, and that's a whole driver training class. That's why Maine requires emergency vehicle operations courses within the first 6 months of hire in any department you work for. That's a Maine licensed service. They have to provide it to you within the first 6 months. New Hampshire does not require that, but traffic vests, ANSI 3 breakaway traffic vests are required on any roadway. Why are they breakaway? Because someone drives by you and their mirror clips you and hooks you into your vest. You don't get dragged down the roadway. It rips off of you. That's why they went with breakaway ANSI 3 requirements. All right. Other things to think about is difficult terrain. I by no means am a skier, and I do not do ski patrol. So if there's somebody up on the mountain, they're bringing the patient to me, right? But difficult terrain, make sure you're wearing the right footwear. Consider traffic safety issues, consider environmental issues. Again, trained people do the job that they're trained to do. In New Hampshire, if we get a wilderness rescue, they have teams that they dispatch out, not fire departments. They have specialized teams that come out that are trained in wilderness rescue, and they bring the patient to EMS. It's not a bad thing. And if appropriate, help protect bystanders from becoming patients, right? The onlookers are more danger than the actual patient itself, right? So keep people away. Hazards range from extreme weather conditions to the threat of physical violence. Every one of you at some point in time, if you do this for a career, or even as a volunteer or per diem, whatever you want to use it for, will run into a time where someone's going to try to attack you in an ambulance. It's going to happen. I'm not going to tell you it won't, because I'd be lying to you. I can't tell you. I can probably count. I can my fingers and toes of times that I've had a patient come off the stretcher and try to hit me. They usually don't get farther than trying. But again, we have abilities to restrain people chemically and physically. So an emergency scene is always dynamic, right? Liquid, fluid, moving around. Nothing is ever routine, right? So from the fire service to EMS, I don't ever want to hear you guys say the word routine, because nothing is the same that we do. Frequent flyers, we call them frequent flyer miles. So they go to the hospital a lot with us. Does not mean it's the same. They may call over and over and over and over again for the same thing. And once you start becoming complacent, you're going to miss something that could be critical that 5th time that they call. All right. I've seen it happen in areas that I've worked in before, where they went to the same person all the time and they blew it off. Come to find out, this patient was actually very sick and was admitted to the intensive care unit for 2 weeks because they blew it off, because they kept going for the same person all the time. Right. So always do an assessment, never not treat somebody. Remember how Morgan was talking about in the last class with medical legal, and I think Zach jumped in a little bit too with that kind of stuff, how I could be called as an expert witness. I could be called as an instructor with over 20 plus years experience, could be called to the court to testify against you, to say this is the proper way of doing an assessment based on the National Registry standards and state protocol. And if you didn't follow it and you violated it, that's negligence. Negligence puts you in jail, loses your license. So never not treat somebody. Always treat people to the fullest extent on every single call based on your protocols. Very important. Calls for assistance can be categorized as medical conditions, traumatic, and or both. Right? So we look at what they call the MOI, the mechanism of injury, or an NOI, which is nature of illness. So calls for assistance they may respond to may be categorized as these. Traumatic injuries are the result of physical forces applied to the outside of the body, usually from an object striking the body or the body striking an object. We'll get into that when we start talking about trauma and the mechanics behind it, right? But even, and again, one of the things that we see a lot of now is we get dispatched to the reported lift assist, right? There's no such thing as a lift assist, okay? If a patient was on the ground, they fell. It's still a fall. Now, do you have to transport them every single time? No. But do they deserve a full assessment? Absolutely. Unless they tell you absolutely pound sand, don't touch me, just pick me up. Again, they're still oriented. You're still assessing them either way. They just don't know it. Blunt trauma. So the force that occurs over a broad area. Okay. So for patients who have experienced traumatic injuries, determine the MOI. And then terms commonly associated with MOI would be like the blunt trauma or penetrating trauma. So penetrating being something that enters through the skin, right? Blunt force trauma or blunt trauma that's over a broad area, those forces that are there will be something like a baseball bat hitting your entire body, or you hitting a steering wheel in a motor vehicle accident, blunt force trauma of you falling off a roof onto the ground, right? But nothing is penetrated through the skin itself, right? And we'll get into penetrating trauma after. But the skin's not broken, tissues and organs of the area impact may be damaged. The drawback with this is you don't know what's going on underneath the skin, so you have to look for different signs and symptoms to kind of have an idea of what potentially could be damaged. Penetrating trauma is the force of an injury that occurs at a small point of contact between the skin and the object. So open with wound with high potential for infection, right? This is why Maine, with open fractures, have given the approval for Maine paramedics to administer procethin or ceftriaxone, right? Which is an antibiotic. You more specifically, a class 3 antibiotic, but that can be administered 1 gram to help prevent that quick infection that potentially could be happening. So it's given over 10 minutes, right? New Hampshire has it for medics and advanced EMTs for the expanded scope practice for your long carryouts. If approved by a medical director, then you can carry the Rocephin on the ambulance. For medical patients, determine the nature of illness, the NOI. So similarities between MOI and NOI there are similarities between them, but one is more of a medical versus mechanism versus trauma. So talk with the patient, family, and bystanders and use your senses to check for clues, right? You always have to be observant, look what's going on, and have conversations with your patients. Talk to them, right? Like I said before in the beginning of class, right? If you are shy, you're not going to be by the end of class, right? Shy people don't usually make it in EMS. And I'm being completely upfront and honest with you, because you have to have that ability to have those conversations and ask those important conversations. So young males will have a hard time talking to a female about sexual encounters or anything that has to do with gynecological type emergencies, right? Now, many men have a good time talking with women about, their sexual encounters that they've had, but it's part of our job to do that assessment to find out what's been going on. Because I can tell you right now, if a lady is pregnant whose water's broke and they're 39 weeks and they've already had 5 other kids through a vaginal birth, that number 6 kid is coming out quickly. Right? So you've got to ask those important questions, even to the point where they've ever had any abortions or miscarriages, right? And sometimes that can be a hard thing to ask somebody, but it's part of our job to do that assessment, right? So talk with the family, talk with the patient, talk with the bystanders that are there, depending on what the situation is, and get the information, right? An unconscious patient laying on the ground, I'm going to start asking bystanders, what happened? Did he get hit by a car and thrown? Did he fall off a roof? Or do you walk up to the park bench finding them unconscious and there's a needle laying on the ground? Right. So we got to figure out what's going on. We have to look at our senses, look at our clues. So be aware of this. Be aware of scenes with more than one patient with similar signs and symptoms. We just talked about that. The auto dealership or body shop with 5 people unconscious, right? Or you respond to a residence where people are complaining of having a headache. That's interesting. Angry dogs. 5 people complaining of headaches. Okay, what could that be? What are your thoughts?
CO2 poisoning?
CO poisoning, but yes. Yep. So it could be CO poisoning, or nowadays, since what's making a comeback right now? COVID.
Oh,
Oh.
yeah.
COVID's making a comeback and everybody's getting it again. Now, it's not as bad as the original COVID-19 or the Delta variant, but we're starting to see a lot more of that now. There's a lot of dogs across the campground here making a lot of noises. Oh boy. So this could indicate unsafe scene for the EMT as well. So considering the MOI or NOI early can be of value in preparing to care for the patient. So if you may be tempted to categorize a patient immediately as either trauma or medical, but it could have been a medical causing a trauma, right? Or could have been a trauma itself, right? I've been to calls before, motor vehicle accidents, where I get there and then they're like, oh my God, start a helicopter, his patient's unconscious in the vehicle. And you look over and you see a half-eaten candy bar. What are you thinking now?
Low blood sugar.
Yeah, diabetic. Check a blood sugar is 20. You cancel a helicopter, they went off the road and crashed their car because the blood sugar is tanked for hypoglycemic, right? So you have to use differential diagnosis to treat a patient and don't always assume something's medical or something's trauma, right? I've seen patients before that have been unconscious and come to find out they were involved in a fall a week ago at a nursing home. This happens quite often, right? You get called for an unresponsive patient in the nursing home, and you ask them a question. Oh, they must be unconscious. I'm not sure maybe they're having a stroke. I'm not sure what's going on. Come to find out, they actually fell a week ago, went to the hospital, got diagnosed with nothing, sent home with a normal CT, but the bleed was so small in their head they had a subdural, and wasn't picked up on initial CT. A week later, now it's pressed so far into the brain that's caused hemispheric shift, and now they're unresponsive, right? So trauma causes a hemorrhagic bleed, right? So we look at all these different things that potentially could be there. And nursing homes are notorious for doing that. Oh, he just fell out of bed and shook his head. We put him back in the bed, and a week later, now he's unconscious. Well, I wonder why. Maybe you should have called a week ago. Don't actually say that to the nursing staff. They get a little upset. But but being all truthful, though, it's like you got to look at
we
everything.
might get a little upset.
Oh, just a little. But I'm not saying that you're incompetent, but no. But in all fairness, though, this happens quite often. We see that, right? And the other things too that we see in nursing homes are we're dispatched for the respiratory distress, and they put them on a non-rebreather at 4 liters a minute, laying down flat. So let's sit them up, take that non-rebreather off, put a nasal cannula on, because too much oxygen really can hurt somebody. And we're not going to get into too much in detail about oxygen and free radicals and all that kind of stuff. That's another day. But this can actually truly hurt a patient, But again, we have to go in there and do our assessment. What is the nature of illness? What is causing this to happen? Right? So don't always think that it's going to be medical and then trauma or trauma then medical. Look for signs and symptoms. Gray Turner sign, Cullen's sign, right? Again, we'll cover those later in abdominal trauma. But there's things that are out there we can look for. Kerr's sign being another one, right? Another one is called, I remember the name of it, Chekhovic's sign or something like that, I think it is. That it has to do with a patient having appendicitis. Looking at McBurney's point. Well, again, abdominal assessments, we'll cover that. And we'll be able to see the differences looking at all these different signs that are out there that we need to be familiar with. Wearing personal protective equipment at minimum, on every patient contact, now that we're post-COVID, is gloves. And with COVID making the comeback that it is right now, the state of South Carolina is actually thinking about doing another mask mandate again for all EMS providers because it's coming back quickly. Right? Take precautions, wash your hands, protect yourself. Right? Wear gowns, gloves, things like that if you have a delivery, because those make a mess. All right. And we'll get more into that in OBs. Standard precautions have been recommended for the use of dealing with objects, blood, bodily fluids, or potential exposure or risk of the communicable disease. Right? We've been so stuck on COVID in learning about COVID that we forget about the fact that respiratory patients could be tuberculosis. Right? And TB is an airborne pathogen that will blow through a surgical mask. Okay? We have to be wearing N95s, NVOs, all right, HEPA filters, anything that protects us from getting an airborne pathogen. And COVID will blow through a surgical mask. Don't even think those are protective at all, because they're not. Not to COVID. It'll get right through it. Right? So again, we need to protect ourselves. So the concept of standard precautions assumes that all blood and bodily fluids, except sweat, or non-intact skin, mucous membranes, may pose a substantial risk of infection. Right? So when you step out of the EMS vehicle and before you actually have patient contact, standard precautions must have been taken or initiated. At a minimum, gloves must be in place for any patient contact. And again, consider wearing glasses and a mask. If you're doing anything with airway, anything that has to do with airway management, okay, and I'm not talking about putting an honor breather on a patient. BVM, entering and putting OPAs, NPAs, SGAs. Again, we'll get into that during airway, right? Those require a mask. Those require goggles. Why? Because they can spit up. And the last thing you want is some person who's unresponsive that has a sudden bout of vomiting, projectile vomiting. It's all over your face, in your mouth, in your nose, in your eyes. You don't want any of that to happen, right? And I've seen patients projectile vomit from laying on the stretcher that hit the ceiling, right, of the ambulance. So protect yourself the best you can. So during scene size up, accurately identify the total number of patients. How many patients do we have here? Motor vehicle accidents are some of the toughest ones to determine because you have all the bystanders that drove up and pulled on scene saying, I want to help. Oh, are you a patient? No. All right, then go stand over there. Who is actually a patient here? So we need to know how many we have. That way there we can determine the need for additional resources or ambulances. Right, this is very critical. We need to know how many patients we have and the status they are. They have status 1, status 2, or status 3. Right? Status 1 patients are critical. Status 3 are not. Right? So priority 1 or status is what they call it. Right? So we look at priority 1, 2, and 3 patients. When there are multiple patients, use the incident command system, identify the number of patients, and start beginning the triage. We haven't covered mass casualty incident yet, but an MCI, right, does not mean it has to be 500 patients, right? You could have a motor vehicle accident, 2 vehicles head on with 4 patients all unconscious, 1 ambulance. Is that an MCI? Absolutely.
Yes.
Yeah, because it's more patients than your resources can handle at that time. All right. So when you're looking at the picture here, the figure showing multiple patients used an incident command system for additional resources and then began triage, multiple casualty incident involving 2 trains that collided in 2005. All right. In North Berwick, Maine, quite a few years ago, we had a train accident. We had 100+ patients we had to deal with. At the end of the whole thing, only 5 or 6 got transported by ambulance. Everybody else was walking wounded or had no injuries at all. That's an MCI as well. So triage is the process of sorting patients based on the severity of each patient's condition. And again, we're not going to get into MCI and how it works, but there's 4 different categories. There's black, green, yellow, and red. Red being the worst, black being deceased, Yellow is like immediate versus critical, and then green is walking wounded. They're perfectly fine. And we'll get more into that in detail during MCI training that we do. Consider additional specialized resources. So some situations may require more ambulances or maybe a specialized team. So what you're seeing in figure 10-6 involves a toxic substance. Those are called level A hazmat suits, right? There's two different methods they can utilize with those. One, they can wear an SCBA underneath, or two, they can have a feeder line going directly to their mask inside, feeding them breathable air. So 20.98% oxygen, and we'll be going inside of that. So that's an option as well. We are not trained to do that as EMS. That is a hazmat technician level certification. That's 40 plus hours of education and training and everything else, and a lot of testing. And we'll talk more about hazmat stuff when we get into our specialty rescue stuff towards the end of the class. Some other specialized resources include advanced life support. Where's the paramedic coming from? Or advanced EMT. Aeromedical support. Where's your closest helicopter going to be coming from? And how many do you have as a resource? Fire departments, who may handle high angle rescue, hazardous materials, or water rescue. Right? This class does not certify you in any of that stuff. Law enforcement. To determine if you need additional resources, ask yourself, does the scene pose a threat to me, my patient, or others? How many patients are there? And do we have the resources to respond to their conditions? All right. Any questions at this point so far? No? Before we start tackling this, because primary assessment, we start getting more in detail, let's take 5 minutes. Actually, let's take 10. We'll come back at 7:11 and we'll hit up this a little bit farther. Okay, let's take 10 minutes. All right, everybody back. Remember that I can't see all your cameras, so.
We can't see you either.
Yeah, I have a lot of issues going on with my stuff right now. But I'm not sure why.
You're having some issues, are you?
Too many of them. The internet here is not the greatest, so when I start running more stuff, it tends to slow things down, and it's shutting off my split screen.
Are you back in South Carolina?
No, not yet. I'm still in New Hampshire. I'll be here until, oh God, I have to be back down there by the 15th of October.
So will you
So
be at our practical on Sunday?
this coming Sunday, I'm going to try my best to be up there for it. I will be there October 1st though to do the CPR class.
So will Morgan be running it on Sunday?
Morgan and Scott should both be up there on Sunday.
Awesome.
Hey, Kev,
Yes.
when the CPR date, so I just recertified I think I want to say April. So do
Yep.
I put October or do I put
So if you're going to
April?
use your current, and it's AHA BLS, right?
Yeah.
That you have?
Yeah.
All right. Yeah. Then put down your expiration on your card.
Okay.
Yep. So you don't have to show up for the CPR class. You just got to be up at AVH by noontime.
Okay.
We're going to be doing hands-on practical assessments as well.
Yep.
We also have scope of practice stuff we have to do too for New Hampshire, like supraglottic airways and 12 lead monitoring and all that.
Okay.
So, all right. Well, let's get started. We might be here till 10 o'clock. So, this is a quite a long lecture. I like to go in detail. Morgan, do you have anything you want to add so far to this point? Feel free to jump in too.
I don't. You're doing really good. I'm actually learning a lot.
Oh, not a problem. All right. So again, sometimes I like to go a little more advanced into like the A level stuff for assessment, but it just makes you a better EMT and what to expect and what to actually say, wait a minute, I can't do this. So I need to call for somebody else that can. So I try to make sure I go to that different level. So let's talk about primary assessment. So this begins when you greet your patient. Now keep in mind that they are calling you at their worst time. I don't care if it's a stub toe to the cardiac arrest, right? They call you at their worst time. And because of television, they expect everybody to be a paramedic now, which we're all not, right? And they expect the best when you walk through the door. That means not just knowing what you're doing, but also looking the part. So make sure you're dressed presentable. Don't show up as a volunteer with holes in your jeans and grease-covered shirts and your hair all a mess and your face covered in oil and dirt and everything else, because they're not going to trust you to do the job that has to be done. You got to look the part, present the part, and know the part that you're working in, right? So this begins when you greet your patient, when you make your attempts to start talking to them. So the goal to identify and initiate treatment of immediate or potential life threats. This is part of your primary assessment. So physically examine the patient and assess LOC and ABCs. LOC is level of consciousness. ABCs are airway, breathing, circulation. Okay. We'll get into deformities and exposure another time with ABCDE later, but we'll focus more on ABCs: airway, breathing, circulation, and level of consciousness. Right? So, level of consciousness, we're going to start asking the patient questions. And hold on here. There we go. So, to do that, we need to form our general impression. Is the patient sick or not sick? So, form to determine the priority of care. If the patient is sick, we need to, I don't want to use the word load and go. The load and go days are gone. We need something to treat our patients, right? But we can also have a chance to stay and play if the patient's not sick. Doesn't mean we sit there for half an hour, 45 minutes. We still have to shoot for that no longer than 20-minute on scene time. Anything longer than 20 minutes, states are starting to look into things. I just got an email today from Maine EMS, and Maine EMS is cracking down hard for long on scene times now. And they're looking at the reports at the state level, right? So 20-minute mark is good, right? I wouldn't go much more than 20 minutes unless you actually document your narrative on why you took longer than 20 minutes, right? So does the patient have an open airway? If they are talking to you and you are talking with them, their airway is patent. Now, breathing status. If we're assessing their breathing and they're, let's say, they're talking like I am right now, they're breathing normal. But if they can't get more than 2 words out at a time like that, we just look at what they call word dyspnea. Dyspnea being shortness of breath, right? So word dyspnea. So how many words can they get out before the next breath has to be taken? And that is very important in assessment to check someone's respiratory status, right? So again, it's called word dyspnea, right? Circulation. What does the patient look like to you? What is their skin color and temperature? Feel a radial pulse, all right? And some rules of thumb. Again, rules of thumb, not testing knowledge. I want to teach you some street stuff here now. If the patient has a radial pulse, their blood pressure has to be right around 90 systolic, the top number, right? If they don't have a radial pulse and they have a carotid pulse up by the neck, their blood pressure is at least 60 systolic, okay? We always start with a radial first. On a pediatrics, we use a brachial, but on adults and children, not infants, all right, we check a radial pulse. A radial pulse is located, if you follow your thumb down, okay, you start going medial, or not medial, sorry, proximal, not distal, but proximal towards the elbow, right? Just about where the carpals start, and you put a little bit of pressure there on the underside of your wrist, you should be able to feel your pulse. Okay, that's what we're going to check for, right? So airway, breathing, circulation, level of consciousness. Are they alert and orientated or not? And we're going to assess 4 things on alert and orientated. One is going to be person, place, time, event. All right. What I usually do is month, day, year, president, or something that may be something they should know the answer to. Right. Now, if they say it's April, the president is Nixon, right, and the year is 1944, right, that's going to be a problem. Now, I know Nixon wasn't president in 44, right, but I'm just throwing that out there, though. If they say those different things, we know that the patient is not alert and oriented, and they don't have the, not capacity, but competency, right, to make decisions. They're not competent enough to make the decision to actually be refuse any type of care. All right. We look at competency and capacity. Right. So I mean, actually rephrase, let me go back. We have the right to determine their capacity. We cannot determine someone's competency in the field. We can do capacity only. Right. So make a note of the person's age, sex, and race, level of distress, and overall appearance. Right. Also train of thought for a minute. So this is formed to determine the priority of the patient and the first part of your primary assessment. As you approach, make sure the patient sees you coming. Do not startle them. All right. Let them know you're coming in the door. Hi, he's knocking on the door. Hi, we're here with EMS. As you approach, my name is Kevin. I'm a paramedic. Why did you call EMS today? Oh, well, this is what's going on. Okay. Can you tell me more about it? Sure. I had to ask you a couple more questions. You know where you are right now? Who's the current president? What month, day, and year is it? Okay, perfect. Then we look at the other thing, what we call Glasgow Coma Scale. The Glasgow Coma Scale is a range between 3 being the lowest score, 15 being the highest score. And we want the higher the score, the better. And it looks at 3 different sections: eyes, verbal response, motor response. And those are done between a scale of 1 to 4 for eyes, 1 to 5 for verbal, 1 to 6 for motor response, right? And that's going to be huge for us when we start doing medical and trauma assessments. We'll get more to that a little bit later, right? We want to note the patient's position and whether the patient is moving or still. Are they prone? Are they supine? Are they left lateral recumbent? Are they semi-Fowler, full Fowler position, right? Are they tripoding? Right, those are different things we're going to look for. So now keep in mind, prone being on your face, face down, supine being face up, lying flat, semi-Fowler being about 30 degrees up off the bed for the head being raised. All right, full Fowler position will be up almost like 75 to 80 degrees. Sitting position, tripoding, leaning forward. We see that more in respiratory distress. All right, those are things that left lateral recumbent would be more like for seizure recovery or pregnancy as well, to prevent supine hypotensive syndrome in pregnancies, right? So again, we'll cover that in OB and obstetrics. It'll be a little bit easier then. But those are different positions we're going to know what the patient is in, right? We're going to avoid standing over a patient. Never stand over a patient. I say never. There may be maybe a 1% time you have to do it, right? Very dangerous. Patient can wake up, kick, punch, take you down. Don't put yourself in that situation. Introduce yourself, who you are and what level, paramedic, EMT, whatever it may be. All right. Ask about the chief complaint. So what is going on today? Well, I have chest pain. Well, and then we'll start getting more into the chest pain assessment. The patient's response can give you insight to the level of consciousness, air patency, respiratory status, and overall circulatory status. Life-threatening problems should be treated immediately. If the patient is not breathing, we need to breathe for them. If the patient is bleeding out, we need to put a tourniquet on, right? These are life-saving measures that have to be done during your primary assessment. We look at airway, breathing, circulation, major bleeding. If the patient is not breathing and they are bleeding out, we're not going to start fixing the airway because once their blood is gone, they are dead, right? So stop the bleed, go back to the airway and fix the airway after that. All right. Define whether your patient's condition is stable but potentially unstable, or unstable, or to direct or further assessment and treatment. So that's our general impression. Are they sick or not sick? Are they stable? Are they stable for now and that's going to change based upon the signs and symptoms that you're seeing? Or are they completely unstable where their vital signs are not meeting homeostasis? They're completely out of whack, right? Like tachycardia with hypotension and tachypnea. Tachypnea being rapid respirations. Determine if the patient's condition is stable, unstable, or potentially unstable. We just went over all that. Uncontrolled external bleeding takes priority over other assessments. Again, if they're bleeding out, they can't pump blood, right? Now, in the human body, we went over some stuff, right? What's important in the blood to transport oxygen? What's important in the blood that transports oxygen?
Red blood cells.
Blood cells.
Red blood cells, exactly, 100% correct. Otherwise known as hemoglobin, right? Hemoglobin attaches, rephrase it, go back. Oxygen attaches itself to hemoglobin, which then transports through the body with the heart pumping. As the body pumps blood through that, it goes to the cellular level, to the capillary beds, which then oxygenates the system, right? So if we don't have blood, or a lack of blood, and the patient is not perfusing appropriately, we now have something called shock, right? So the patient has to be able to, or more in depth, more in detail, that hypovolemic shock, right? So again, we have to understand what's going on. If the patient is bleeding out and they don't have red blood cells to transport oxygen, we're not going to get into a complete blood count tonight, right? We'll cover that more stuff later during trauma and things like that. Other things that are part of it between hematocrit and hemoglobin stuff and all that, kind of looking at different things. But what we're going to cover tonight, though, is if they're bleeding, we have to stop it. And if we don't, then we can't perfuse the system appropriately. An inadequate state of tissue perfusion is the definition of shock. Shock can kill people. All right. Whether it be neurogenic, septic, right, distributive. There's all different types of shocks that are out there, and we'll cover that during our shock assessment. The level of consciousness can tell you a great deal about the patient's neurologic and physiologic status, right? If they're altered, we got to find out why. Is it a stroke? Is it a diabetic emergency? Is it alcohol? What could it be? And that's where we start looking at our differentials to find out what potentially that could lead into. Assessment of the unconscious patient, we want to focus on airway, breathing, and circulation. Right? ABCs. Sustained unconsciousness should warn you that a critical respiratory or circulatory or central nervous system problem or deficit might exist. Right? We talk about traumas and unconscious. The term trauma naked will come out a lot with me. If the patient has a traumatic event, they are unconscious, their clothes are coming off. We have to be able to see everything, right? Including genitalia. That's also very important because an erection in a male on an unconscious trauma, right, is what they call priapism, which is indicative of a spinal injury, right? So again, things to look for. If there's vaginal bleeding, we do not pack anything inside the vagina. That is against our protocols. We just put a trauma pad underneath it and collect it. We just collect the blood pad over it. Doesn't stick anything inside. We'll talk about the only circumstance you put your hands inside, and that'll be in obstetrics. So again, respiratory, circulatory, or central nervous problem, right? We have to be able to do assessments to find out what's going on, looking at pupillary response and things like that. We'll get more into that in detail a little bit later. Conscious with an altered level of consciousness may be due to inadequate perfusion. We just talked about shock. Why are they not perfusing appropriately? All right. Could it be a pulmonary embolus? Could it be a heart attack? Could it be a stroke? Right? Could it be hypovolemic shock? Could it be septic shock? Could it be diabetes? I'm throwing a lot of different things out there that could change someone's mental status. We just have to figure out why. This could also be caused by medications, drugs, alcohol, or poisoning. When we cover toxins, I'm going to go over toxidromes with you guys. And I expect you guys to have the toxidromes memorized because you never know when you're going to come in contact with either organophosphate, anticholinergic syndrome. Again, big terms now. We'll cover them more in detail later. But I just want you guys to be familiar with toxidromes as well. So if you don't know what they are, you can start researching them soon and kind of get an idea of what we're going to be discussing. I'm very big on toxins and understanding how those things work. To assess for responsiveness, use the mnemonic AVPU, or what we call AVPU. A is awake and alert. V is responsive to verbal stimuli. P is responsive to pain. And I'm talking about inflicting pain. Sternum rub, trapezius pinch, things like that. Or U, unresponsive. Oh. So the test here, you can see how they're pinching the cheek, pinching the trap, or doing a sternum rub. When you do a sternum rub, take your knuckles and you drive them. Don't punch the patient, please. Place it on their sternum and you rock your hand back and forth with your knuckles on their sternum. That's a sternal rub. Trapezius pinch, those hurt a lot, right? But if they're unconscious, we need to find out they wake up. And I've had patients that I've wrenched on someone's trapezius and they did not even flinch. Those guys are out. All right. The other one is pinching like the earlobe and the cheek as well. Another thing you can also do is pinch the back of the upper arm where your triceps would be. And that is also very painful as well. Other thing you can do is applying upward pressure along the ridge of the orbital rim as well on the underside of the eyebrow. I don't like pushing on orbits because those are one of the most commonly fractured facial bones because there's not much to them. So orbital fractures are more common, which then in turn you'd find something called a term called raccoon eyes. Orientation tests mental status. Evaluate the patient's ability to remember person, place, time, and event. So a person could be remembered as his or her own name. A place you could identify the a current location. Like, what's your address? Right? Time, current time of year, month, or approximate date, and events. Describe what happened as well. Evaluate long-term memory, immediate-term memory, and short-term memory. Right? So to remember short-term memory stuff, you can ask them to remember 5 things. Right? If you're going to do that, make sure you use the same 5 every time or write them down so you don't forget, because that would look pretty bad if you forgot the questions you were asking your patient. Right? So I could say to Fred, can you remember purple, green, yellow, black? And then in 5 minutes from now, I'm going to say, remember those 4 colors I asked you to remember? And he says, elephant, dinosaur, peanut butter, and jelly. Well, that could be a problem, right? Now he has some potential neurological issues going on where he has short-term memory loss.
I'd say Skittles.
Skittles. Just like, hey, you got all the rainbow colors. You're good, I guess. Right. So any deviation from this, from that would make a person altered, or anything from the patient's normal baseline. So what if I told you responded to a 95-year-old male acting confused, and you get there and they said, well, he has a history of dementia. Well, they're normally confused anyways. So the question I would be asking the family is, what is different today compared to yesterday? Well, now he's not acting normal at all. There's a lot of different issues going on. He seems to be leaning more to the left side. Okay, now we're getting somewhere. Now we're looking at a better assessment. Now he has a list to the left side, that lean. He's becoming more altered. Now I'm going to do a stroke exam with this guy, do a full neurological assessment. That makes sense? Right? What is different today than it was yesterday? You have to make sure you're asking that question. Conditions that cause sudden death would be airway obstruction, respiratory failure, respiratory arrest, shock, severe bleeding, and primary cardiac arrest. Right? So we got to identify the life threats and make sure we treat them. If we have someone who is breathing 50 times a minute, and I'm not talking about a pediatric or an infant, all right, we'll talk about respiratory statuses a little bit here, right? If they're breathing 50 times a minute with an adult and a blood pressure of 60/20 with a heart rate of 150, are they coming close to death? Yeah, I would say yes. That's what we call compensated shock, right? We have to be able to treat that. That's an ALS call. They need to get IV fluids potentially in this patient, or what else is causing it? Is there a bleed somewhere or things like that? So a lot of things we need to look at. Again, we want to make sure we identify those life threats. In most cases, begin with airway, followed by breathing and circulation. And in some cases, it may be appropriate to address life threats, the circulation first, CAB. And in that case, it would be cardiac arrest, right? We start compressions first and airway and breathing. Again, if you're not circulating blood, you cannot oxygenate the system. So moving through the primary assessment, stay alert for signs of airway obstruction. If you have an airway obstruction, we do what? What do we do?
Remove it.
Try and clear it.
Exactly. Clear the airway, right? And ensure the airway remains open and patent. You may be on a medical call where you never get past airway, right? Bleeding has been controlled, and now they have an airway compromise, and you're stuck on airway. Can't go anywhere else, so that's clear because the patient's going to die. Call for more help. It has to remain open and patent and adequate for the entire transport. We got to do whatever we can to make sure that happens. Responsive patients, obviously patients who are talking or crying have an open airway. If a baby is crying, that's a good thing. We like crying as EMS providers. Crying is a good thing, right? Patients who are talking or crying, the airway is open. Watch and listen to how patients speak. Do they sound slurred? Right? That's one of the big things you got to look for is slurred speech. That could be indicative of a stroke. It's also one of the 3 things we look for on what they call a Cincinnati stroke scale. So if you identify an airway problem, stop the assessment and work to clear the patient's airway. Once it's clear, move forward. On responsive patients, we want to identify, immediately assess the airway. We want to make sure we use a jaw thrust technique because we're not sure if it's traumatic or not. If it's a non-traumatic issue, then we want to look at a head tilt chin lift. Because relaxation of the tongue or the tongue muscles is one of the causes of airway obstruction. So there's one device that we're going to cover on the next chapter on Thursday, which we're going to call an oral pharyngeal airway, OPA, that'll help displace the tongue to allow the airway to maintain patent. However, if the patient has a gag reflex, we cannot put it in because it will trigger a gag reflex. Signs of obstruction in an unconscious patient. Obviously, obvious trauma, blood, or obstruction. We got to suction the blood out. Noisy breathing, snoring, bubbling, gurgling, crowing, right? Abnormal sounds like that. And we'll cover, like I said, during we do chest assessments, we'll cover more in depth on lung sounds. Extremely shallow or absent breathing. We need to make sure we're looking for this and treating it. Make sure that the patient's airway is open. Make sure the patient's breathing is present and adequate. So ask yourself this: is the patient breathing? Is the patient breathing adequately? And is the patient hypoxic? So how can we tell, because I'm sure all of you guys read your books, how can we tell if a patient is hypoxic?
Skin.
Okay. And what specifically in the skin are we looking for, and what color?
Blue,
We look blue.
dark.
Yeah, blue.
Grayish, dark blue.
Cyanotic.
Yeah, darkish color. So the answer is cyanotic. Please do not call in a read report saying they have Smurf-like tendencies. All right. All right. But the patient is cyanotic. We look for that blue tint. Right? So what if the patient's African American? What do we do?
Palms.
Palms and
Eyes.
Lips.
Feet.
eyes, lip. So otherwise known as
Fingernails.
the mucous membranes. Right? So pull their lips down, pull their eyelids down, palms, fingernails. Right? There's other ways to look for it as well. Good. I'm glad none of you guys mentioned SpO2 because I can tell you right now, SpO2 is just a tool. It does not replace what you have in your head and your brain and what you look for. Right? Pulse oximetry is another way we can look at it. There's 2 things we're going to cover. One is end-tidal CO2, and the other one's pulse oximetry later on. One measures more perfusionary status, while the other measures oxygenation. We'll cover that later. So consider providing positive pressure ventilation with an airway adjunct when the patient has respirations exceed 28 breaths per minute. Right now, these are book numbers, okay? Respirations that are fewer than 8 breaths a minute, you also want to provide a BVM. If the patient's sitting there and they're breathing 8 times a minute and they're alert and oriented, please do not take a mask and put it on their face. All right? Start bagging them. All right? We look at 8 and 28 as numbers that you're going to be tested on. But again, real world, look at the patient's status. Do they need a BVM? Yes or no? We'll cover more of that in depth when we get into respiratory emergencies. The goal for oxygenation for most patients is an oxygen saturation of approximately 94 to 99%. Guess how we don't do 100 anymore. We don't ever want to see anybody at 100% because now we really can't measure how much oxygen is truly in the system and if we're over-oxygenating a patient. Giving somebody too much oxygen can increase their PaO2 to levels that you don't want to be at. I'm talking levels in like the 400s, okay? That can only be measured by a blood gas, which we cannot do even as paramedics in the field, right? Respiratory therapists come in there and they do an arterial blood gas, or even they can do a VBG too, venous blood gas, and find these numbers out. But again, Oxygen is good for a patient, but if they don't need it, don't give it. That's my clinician side for you guys. On a testing standpoint, right? Give oxygen to these patients based on a testing standpoint. I want to make sure that I'm training you guys and not just how to pass this test, but what's you guys really going to see in the real world as you approach it, right? So that way you're not looking like a cookbook provider. You're actually thinking. Observe how much effort is required for the patient to breathe. Respiratory status. This is very important. Retractions, right? Looking at that accessory muscle use and retraction in the accessory muscles up by the neck, things like that. Nasal flaring. We see a lot of that in pediatrics, where the nasal passages get very wide. 2 to 3 word dyspnea. We talked about that already. Tripoding, sniffing position, labored breathing. One of the ones that's not on here is pursed lips, right? Here's a little respiratory knowledge here, right? Our body requires something called PEEP. Anybody know what PEEP stands for? It's okay if you don't. I haven't taught it yet.
It's in the terminology we just did, but I can't remember what it means.
That's fine. It's called positive end expiratory pressure. Okay. Our vocal cords provide a PEEP of 5. All right. So what I want you guys all to do, and yes, I know you're on camera, is open your mouths nice and wide and take a breath in and back out. Right? In and out, mouth wide open. How fast did that air come out of you? Pretty quickly? I want you to do the same thing again, but give me some pursed lips, like you're trying to give somebody a kiss, and blow back out that way. Does it take longer for your lungs to expel air?
Yeah, it's way slower.
It's slower. Patients that have COPD, emphysema, bronchitis, chronic bronchitis, things like that, are going to do something called pursed lip breathing. And that is their body's mechanism to create higher PEEP. Patients with COPD exacerbation require continuous positive airway pressure, CPAP, which all you can do, with higher levels of PEEP to allow for the lungs and alveoli to stay open longer to allow for better gas exchange and to become oxygenated. And we'll cover more of that in detail when we start talking about respiratory therapy stuff, which is what we can do a lot of. And they've given EMTs a lot of leeway now in more tools. Right? Any questions on breathing stuff so far? I kind of covered a lot of different terminology there. Everybody good? I can't see your cameras, so just gotta let me know.
Yes, we are.
Perfect.
I can.
Yes.
Kevin, under labor breathing, there's a name, I'm gonna say it wrong. It's like not snoring, but like kind of like a gargled noise, but they're breathing. They're making there's a name for it. I can't think of it. Starts with an S, I think.
I'm trying to think of what you're trying to explain.
So if like they're unconscious, but they're
Agonal?
no, it's it's almost like a snoring sound where they're breathing, but it's almost like there's fluid in their lungs.
So we're talking about lung
If I think of
sounds,
it,
a
I'll-
little bit different. So there's rales, which is fluid, bronchi, which is like that junky sound, right?
Yeah.
Then you have stridor, which is upper airway, like croup, things like that. Actually, croup's pretty cool to see on a chest X-ray, by the way. And
I bet it's Strider.
stridor would be
Probably.
more of the upper airway obstruction, which would be more of it's more of an infection almost.
All right. So I'll give you an example. Maybe it'll
Yeah.
help it. So somebody fell out of a moving Jeep and landed, and so that when they hit the ground, and obviously they lost their breath, right? Got taken out of them. So they were making that almost like they were got the wind knocked out of them, but they were unconscious.
I can't think of the word you're trying to look for.
All right.
If you think of it, let me know and I'll go more in detail. And Morgan, unless
I
you
will.
got something, Morgan.
No, he described so many things I don't understand either.
Yeah.
That's my. That's all right. It's probably in one of these breathings. I'll look it up.
I'm sure it is. I'm sure you're gonna be say it. I'm like, ah, crap, I knew that. I just can't think of what you're trying to say. But we'll cover lung sounds more in detail too, and the appropriate way to do lung sounds as well, and more in depth. Respiratory distress, so increased work of breathing, increased rate and effort, right? So the question is though, is why? And we'll get into more of that later with cardiac and respiratory is, yeah, I understand the rate is higher, but why is it higher? Are they tachypnic because it's shock? Are they tachypnic with a Cheyne-Stokes respiration type deal because of diabetic ketoacidosis? So a lot of different things we can think about too. So again, we look at respiratory distress, increased rate and effort. We got to find out why it's increased rate and effort. Why is that happening? Are they hypoxic, which is causing tachycardia to bring more and tachypnea to bring more oxygen into the system to move it around faster to the cells of the body? So there's a lot of things that potentially could be, and we'll talk more about that at a later time. Respiratory failure occurs when the blood is inadequately oxygenated or ventilation is inadequate to meeting the oxygen demands of the body. The ultimate result of respiratory failure is a result of respiratory failure if it is not corrected. So again, patients that are in respiratory distress will go into failure, and then failure going into arrest, right? Respiratory arrest means they're no longer breathing. Failure means that things have stopped to the point where they can no longer breathe on their own. When they've stopped breathing, at that point in time, now we're in respiratory arrest. And it doesn't take long before that, before the heart says, you know what, if you quit, I'm done. And they go into complete cardiac arrest, all right? Respiratory patients can decline quickly, very quickly, if not treated appropriately. All right, assessing circulation. We're going to assess mental status, pulse, and skin condition. All right, so alert and oriented, asking those questions, checking that status, checking for a pulse as well. We'll go over more of that here in the next slide. So the pulse is the pressure wave that occurs at each heartbeat, causes a surge in the blood circulating through the arteries. They're palpable in the feet where they are as well. We'll go over that here in a second, but palpate and feel the pulse. And if you cannot palpate a pulse and unresponsive, begin CPR. All right. Let's touch my train of thought. Where I was going to go with that. There are different locations where you can assess pulses within the body, and I'm sure that they went over it in human body as well. But we have the carotid, the brachial, right? The radial pulse, the femoral pulse, a popliteal pulse, a tibial pulse, and a dorsal pedal. Those are all different locations that we can check pulses in the body, right? As far as the pulse goes, a little more cardiac stuff here as well. I'll tell you more about that as well. Every time you feel your pulse beat, that's your ventricles depolarizing or squeezing blood, right? Remember, your atria pumps first, your ventricles pump second. So you hear that lub dub sound. If you listen to heart sounds, though, right? That ventricle depolarizing or squeezing, pushing the blood out to the body through the left ventricle, right? That's when you feel that heartbeat. That pulse that you feel is your ventricular depolarization, right? Part of the electrical conduction system of the heart. So skin condition, you're going to evaluate the patient's skin color, temperature, moisture, and capillary refill. Right, we have to check on the nail beds or press on the skin. So if you guys all want to try that now, press on the top of your hand, hold your finger down on top of it, and let it go. Your hand should be white, and then it should get colored back within 2 to 4 seconds. If it goes longer than 4 seconds, then we have inadequate tissue perfusion. All right. A normally functioning circulatory system perfuses the skin with oxygenated blood, right? So quick anatomy review, right? I'm going to be very quick about it. Blood is pumped through arteries, correct? Into arterioles, into the capillary beds. In that capillary bed, our hemoglobin, or I'm going to call them the dump trucks of the system, dump off that oxygen and take back carbon dioxide, all right, CO2. Then comes back around through the capillary bed into the venules, right, into the veins, and it goes back around into the lungs, where then it is now exchanged through your expiration. So your breath is coming back out, releasing that carbon dioxide. You take that breath back in. Now you're 21% oxygen, 78% nitrogen, all that other crap comes back in your system, right? And then it does the whole thing over again. You breathe that back in, it goes into the lungs. So we start off back at the beginning again, right? The oxygenated blood comes back in, right atrium, right? Through the tricuspid valve into the right ventricle, which then goes into the through the pulmonary valve into the pulmonary system, into the lungs. The oxygenated blood is now gone. Your breath comes in. Oxygenated blood is now picked up in the alveoli, now attaches to the hemoglobin, red blood cells that Fred was mentioning earlier, right? Goes back into the left atrium, to the mitral valve, right? To the left ventricle, through the aortic valve, into the aorta, and then is dispersed through the system, through arteries, arterioles, in the capillary bed. That's kind of how the blood circulates round and round in the body without getting into very big details. All right. Remember, the heart has 4 chambers. Okay. I know this is kind of review of that, but this is also part of circulation. 4 chambers of the heart, right and left atrium, right and left ventricle, and there are 4 valves: tricuspid, pulmonic, mitral, aortic. All right. We're all adults here, right? Acronyms work well, right? Toilet paper my ass. TPMA, 4 valves. Don't forget it. I learned that in school a long time ago, right? But there's ways to remember things. We're not going to talk about cranial nerves today. Those are some dirty ones that are there. But
Okay, yes.
what's skin color, right? Determine the circulating vessels, right? Through the vessels itself. Poor circulation will cause the skin to appear pale, white, ashen, and gray. If we see that, the patient is not doing well. All right. Those are patients that are not perfusing. Those are patients that are having heart attacks, right? Bleeding out. High blood pressure can cause the skin to be abnormally flushed and red, right? Hypertension can cause flushed skin. If you see cherry red skin, the patient should already be dead by now. That's high levels of carbon monoxide in the system. Late sign, patient's already probably dead. Not going to save them, right? So high blood pressure, though, can cause skin to be abnormally flushed. Look at the face, look at the body, right? You can be like, oh, that patient might be hypertensive. And then you check that out. Here's cyanosis on an infant, as you can see around the mouth. That is not what I meant to do. Apparently, I can't select that. All right. I was going to try to click on a highlighter, but apparently it doesn't want me to do it. All right. So you guys can see my mouse anyways, right?
Yes.
Okay. So you can see around the eyes here, but mostly around the mouth here, that blue tint, that's cyanosis that you're seeing. And eventually you'll start seeing it in the arms, and then this you'll start seeing it first here, a little bit on the extremity, and you'll start seeing full body cyanosis on infants if they're not breathing appropriately. So when blood is not properly saturated with oxygen, it appears blue. So changes in the skin color may be a result of a chronic illness as well. So again, let me see that. So here's some bonus points for you guys. Who can tell me when a patient has the cold feeling in their hands all the time? What is that called? When they're always cold, poor circulation in the hands.
Well, my doctor tells me I have Raynaud's.
That's it.
I don't think is that it?
That's it. Yeah.
Yeah.
When your hands are always cold.
Yep.
Raynaud
that's me.
syndrome. Yep. That's it. All right. So normal skin will be warm to the touch. Abnormal skin will be hot, cool, cold, clammy. So what we do with the skin assessment, we look at it to be pink, warm, and dry, right? Pink, warm, and dry is good. Cool, clammy, and diaphoretic is bad. All right. Pink, warm, and dry is normal. As you can see here, skin moisture, dry is normal. Skin that is wet, moist, or excessively dry or hot suggests a problem. We'll get into that during environmental emergencies as well. Capillary refill evaluated to assess the ability of the circulatory system to restore blood to the capillary system. So what we're going to do is we're going to press on the fingernails, top of the hands work fine too. If you're checking on the feet, you're checking on the top of the foot. But the nail bed should restore back to its normal pink color. So if you have your nails, you press on it, it should come back to normal within 2 to 4 seconds. Anything greater than 4 is poor perfusion. It says 2 to 4 is fine. But really, it should be responding back within 2 seconds. We're going to assess and control any external bleeding in trauma patients. So this should occur before addressing airway breathing concerns. Again, major bleeding, control it. Right. Bleeding from a large vein is characterized as a steady flow of blood. Right. Bleeding from an artery is characterized as spurting flow of blood. Right. Veins will be a darker bleed, as arteries will be more bright red in color wise. Right. So if we have it, external bleeding, it can be simple by applying direct pressure and calling it good. We don't do elevate and pressure points anymore. If we can't control it with direct pressure and it's a severe bleed, tourniquet. Right? Direct pressure is not quickly successful or obvious arterial hemorrhage of an extremity. Now, in some states, which they don't talk a lot about, is something called quick clot. Right? The hemostatic agents. Right? Maine and New Hampshire do carry hemostatic agents in their arsenal for EMTs. So we have an extremity bleed that's arterial. We can shove this quick clot inside the wound if it's a packet, or wrap it, and then we can put tourniquets on. It'll help start the clotting process. Basically cauterize. Please do not pour powder inside of those. Okay, it makes a mess, and it's not within our scope. Perform a rapid exam. Identify injuries that must be managed to protected before the patient is transported. All right, this should take no more than 60 to 90 seconds to perform, and not a systematic or focused physical examination. This is another, in old terms, this was called the rapid trauma assessment, or rapid assessment, rapid exam. Right? This should being honest, should not take you more than 60 seconds to complete. But they give you 60 to 90. This helps identify any life-threatening injuries like pelvic fractures, femur fractures, things that you can lose a ton of blood from. Determine the priority of patient care and transport. So primary assessments assist in determining how we need to transport. There'd be priority or not. High priority patients include those of any of the following conditions: unresponsive, difficulty breathing, or uncontrolled bleeding. High priority patients otherwise would be altered mental status or altered level of consciousness, severe chest pain, pale skin or other signs of poor perfusion, a complicated childbirth, complicated being like breech birth, limb presentation, prolapse cord, nuchal cord, abruptio placenta, placenta previa. Well, again, all the terms we'll go over when we talk about obstetrics. Severe pain in any area of the body. And I'm talking about severe pain. All right. It is not our job as providers to tell us or tell a patient that they are seeking for meds. Right? Pain is pain. Let's treat it. Right? The best thing about being EMTs, you guys have 2 pain medications in New Hampshire you can administer. Tylenol and Motrin, PO, oral. So within the scope of practice of an EMT in New Hampshire. The golden hour, the golden period, okay, is the time from injury to definitive care. Treatment of shock and traumatic pain injuries must occur for this to happen. We have the golden hour to get into definitive care, and that means a place that has an OR. Immediate transport is one of the keys to survival of these patients who need immediate care that an EMT cannot provide. Within the golden hour, there's something called the Platinum 10, which they really don't teach anymore. And that's your first 10 minutes of patient contact to make a determination and get the patient out. But the golden hour still exists. Right? Actually, it is still in here. So the Platinum 10 is the initial assessment, intervention, and packaging. You have 10 minutes to make that happen. Discovery of the incident and activation of EMS, 20 minutes, right? Now 30 minutes, EMS transport, initial hospital stabilization. We don't have a lot of time, do we? Right? There's not a lot of time here. Oh, there we go. I got my
So
pen back.
Kevin, earlier you were saying that they're starting to crack down on the 20-minute
Yes.
time. So, but if we have that 10-minute platinum and the 20 minutes, that's actually 30 minutes before you're actually setting sail if you take the full 20 minutes.
Yes. But also keep in mind of where we are actually located too. So
Right.
you want to use Center Ospey, Fred, for you?
Yeah.
Where's our closest trauma center?
20 minutes away.
Portsmouth.
Oh, that's
Portsmouth.
trauma. Yeah.
Yeah, that's our closest level 2 trauma center. Our closest level 1s are Dartmouth and Maine Med. Right? So critical patients may need air medical transport. Right? So we want to make sure that we get these patients in the back of our truck. Quick, rapid trauma assessment here, the first 10 minutes. And let's start loading and getting the patient moving towards a facility. Right? We can do the rest en route. We got to move these patients to definitive care. That's the hospital. Critical access have the ability to do scans. They can hang blood, but they cannot do crazy surgeries. Okay. So the hospitals around here, Memorial and Huggins, they can do orthopedic OR surgeries. They have the ability to do that. But multi-system trauma, they cannot handle. They need to go to a trauma center. They're flying these patients out or sending them by ground. So instead of bypassing or going to out of the way, can we go straight down to Portsmouth? And if the patient crashes, you have 2 freestanding ERs and 2 other hospitals before you get to Portsmouth Hospital. There's 4 other ERs you can stop at along that way from Rochester down. So there's a lot of different abilities or things you can do for that. You just got to plan it and think ahead. What does this patient need now? If they need blood products right away, then call for flight because they carry whole blood with them. Right? They carry O-type blood as universal donors, which means they can accept it. Right? They actually do carry this stuff. They usually carry 2 to 4 units on the helicopter. Transport decisions should be made at this point based on patient's condition, availability of advanced care, and your closest ALS may be the hospital, the physician. So you may not be able to get somebody. Distance of transport and follow your local protocols. Provide history taking. So provide detail about the chief complaint and the patient's signs and symptoms. This is the part where I talking about interrogation. What do we need to do? We're going to cover history taking here, and we'll take a 5-minute break and then continue. Provide detail about the chief complaint and the patient's signs and symptoms. Includes demographic information, date of the incident. It may not have happened today. It could have happened a week ago, and then they're calling today because they're in pain. Patient's age, gender, race, past medical history, current health status. All important information. So we're going to investigate this chief complaint. We're going to start the interrogation here. I love this part. So we're going to make introductions and make the patient feel comfortable and obtain permission to treat. If you walk in and start doing a blood pressure, you have now assaulted your patient, right? You have to gain consent. You need verbal consent, right? When is implied consent taken?
When they're unconscious.
When they're not conscious.
Yeah, when they're not conscious. Exactly, 100% correct, right? So refer to the patient as Mr., Ms., or Mrs. using the patient's last name. Now, if you've gone to this residence multiple times and we can call that patient Sally because that's her name, then we can do that. But if it's your first time meeting them, Mr. Jones, Mrs. Jones, whatever it may be, right? Ask them who they are. Give them that respect. If they say, oh, don't worry, call me Ed. All right, Ed. Then we'll go from there. But at least give them that respect first. And ask open-ended questions. Fred, do you have any chest pain today? Any shortness of breath, dizziness, nausea, vomiting, diarrhea, blurry vision, headache? He's like, yeah, I do.
All the above.
All the above. Right. Those are all pertinent questions you want to be asking your patient, right? They all mean something. But again, if I said, Fred, do you have any chest pain, shortness of breath, dizziness, nausea, vomiting? And he's like, yes. Well, yes to which one? Right? Open-ended questions, but wait for your answer to come back. Start with, do you have any chest pain? Yes. Can you describe to me what it feels like? We start going to our OPQRST, which we'll cover here in a little bit. Right? Do you have any shortness of breath? Yes. Well, what does it feel like? I have a hard time catching my breath. Do you feel like you're drowning inside? I feel like there's a lot of fluid. Okay. Could it be pneumonia? Could it be congestive heart failure? Now we're looking at our differentials because we've asked those specific questions, right? Now, there's more in detail than just that, but that's just the basis of what we're getting started, that baseline assessment that we're doing, right? If the patient is unresponsive, remember implied consent, the patient information and clues about the incident may be obtained from family members, bystanders, a person who may have witnessed the situation happening, medical alert bracelets, jewelry, flash drives, whatever, and other patient medical history documentation. The file of life is still a thing, right? People still have them on their refrigerators. And some other towns are still giving them out in hospitals too. Huggins did it for a long time with a file of life versus the vial of life, the medicine bottle. And the whole entire Huggins catchment area, they were giving them out the ERs for a while. So again, look at that information that's there. You can tell a lot about a past medical history looking at meds. So get good with pharmacology, the basic stuff. And we're going to use the OPQRST mnemonic to assess symptoms. So it's onset. So how fast did it come on? Was it sudden? Is it a chronic illness? Provocation or palliation? Right? Provocation, what makes it better or worse? Quality. Hi, Zach. I can't see anything that's there at all.
Let's see. All right. I was going to stop in real quick on you're talking about being familiar with your drugs. I highly want to recommend this book as a new EMT. It's the EMS Pocket Drug Guide. It's super cheap. It's on Amazon, but it basically gives you a list of drugs and what they're used for. And until you get really familiar, this is a good thing. It's not always great with a patient trying to look it up, but if you know a drug, you can go back to your station, take a look at it. Obviously, you can Google stuff, but sometimes I like just having a book that I can reference. So highly recommend it. Sorry, Kevin. Just wanted to jump in real quick.
You're fine, Zach. The other thing you can also utilize as well is something called Hippocrates on your phone. Hippocrates is great, and it's free. I think it's like EPOCRATES.
Yeah, I just looked it up.
My luck is I never have cell phone service, so
that is true. There's no service down there at all. But the thing is, though,
one is I was going to say the EMS one is also the pocket drug. You can download it for like $10.
I have one on my phone that I utilize for interfacility transport, and it was $50 for that one there, but it's IV medication ones for all the different IV drips out there. But phones are great. iPads are great if your services have them on their trucks and putting these different things that are on there for reference material. But medications are huge, right? And we'll go more into that here later on. But I'll tell you one really quick before we get into OPQRST and we'll take our break. Is beta blockers. Anything that ends in OLOL, like metoprolol, labetalol, things like that. The beta blockers are very important to know because what they do if they block the beta receptor, is they kind of it decreases heart rate. So patients that have decreased heart rate, decreased blood pressure on beta blockers, if they're involved in a traumatic event, normally if someone who has a traumatic event, a trauma, and they're in shock, you would expect to see tachycardia. But if they're on beta blockers, it can mask that and bring that heart rate back down to normal ranges, even though technically they still are in shock. So having an understanding of how the medications work is huge, right? From EMT to paramedic and even up higher than that. And Zach can tell you, being a critical care medic, it gets even worse with pharmacology as we move forward. So there's a lot more stuff we have to know. And it's a lot to it, but understand the basics of what things do. And when we get into toxins and medications later on, we'll talk about lisinopril, ACE inhibitors, and what can happen with anaphylactic reactions later on down the road. But let's go back to OPQRST mnemonics to assess symptoms. Onset, again, was it acute? Was it a chronic onset? When did it start? Provocation, what makes it better or worse depending on what's going on. So an example would be is if the patient had chest pain and it gets worse on exertion. Okay, well then we know that exertion provokes that pain to make it worse. But resting makes it feel better. The quality of the pain, sharp, dull, pressure. Okay, pressure is still a quality. Is it stabbing? Is it a dull pain? Does it feel like something's sitting on your chest? All right. Radiation. Does the pain radiate anywhere at all? Right? Does it go to your shoulders, your back, your neck? Right? We won't get into referred pain and Kerr's sign yet. Yeah, we'll talk about splenic stuff later on and abdominal. Severity. Right? 0 to 10. Okay. I'll try this here. 0. This is horrible. I'm using a mouse pad here, but 0 to 10. 0 being no pain, 10 being the worst pain you ever felt in your life, excluding childbirth. 0, no pain, 10 being the worst pain you ever had, excluding childbirth. And then timing. How long has it been going on for? 3 days, 2 days, 5 hours, 10 hours? I had a patient tell me they had abdominal pain for 6 months. I was like, and you're calling now? 6 months later, right? Then identify the pertinent negatives. This right here is very important. All right. Asking those specific questions that are pertinent that give you that negative response. Right. Do you have any chest pain, shortness of breath, dizziness, nausea, blurry vision, headache, vomiting, diarrhea? All important information to be asking because a lot of that can change things. You'll be surprised at how off your labs can be on an electrolyte standpoint from significant diarrhea and vomiting, especially in pediatrics. We start getting into peds later. All right. Any questions on history taking it all? All right. We'll get more into the sample history too in a little bit, but I just want to kind of, which will be on our next slide. But let's take 5 minutes. We'll come back at 8:20 and we'll continue on. Yeah, I don't know if it worked or not. I just put some screenshots of my phone on the chat group, on the chat side. And in there are some apps that I use for medical stuff. Some have some cost to it, some don't. Some, like PD Stat is phenomenal. I like PD Stat a lot because of what it can do for pediatric dosing and different treatments for pediatrics. So I just don't know if it went through or not. It's not showing it actually sent, but maybe it did. I'm not sure.
I can see it.
Yeah,
You can?
I can
too.
see it.
Yep.
Awesome. So if you're looking at those apps that I have down there, the first picture, you see something called Join Triage. If you're going to work in Massachusetts or New Hampshire, you have to use that Join Triage app. It's something for what they call a fast ED score for strokes. And that's also free. Don't create an account. You can do it for nothing. Hippocrates is also free. The PPP app on the second photo is called Paramedic Protocol Provider. But all reality, though, is that's every state, for the most part, every state's protocols. You can just download them. So I have it from Maine, New Hampshire, and Mass, and all that stuff too. The intravenous medication one, that's like $50 something. I use that for critical transports that I do. Wiser is a good one to have too as well. That's all hazmat and it has medical treatments in there. I'm not sure there's a cost of that now or not. I can't remember anymore. Escavo, or the sepsis one, that's actually pretty good for sepsis treatments if you're looking for any good information at all. And I like the neuro toolkit too. That's pretty cool neuro assessments in there, including an NIH assessment, which has like the pictograms and all that. So it's pretty cool. But I do have my phone opened up on this as well, signed in. So if you want to send a message, I should be able to see it on here as I'm monitoring it, but you're better off just jumping in and talking. You don't have to raise your hand or anything else. Just let go and just have a conversation. But you guys ready to get started?
Yes.
Yep.
All right. I see Zach saying hello. Perfect. All right. So let's talk about the sample history. So the sample history, I like to call it ample because we already know what the signs and symptoms are. What just happened to my thing here? That did not work like I had planned. Apparently I lost my laser pointer. All right, whatever. Not a big deal. All right, so signs and symptoms as part of the S. So what you can see, what the patient tells you. Allergies. Does the patient have any allergies to medications? M is medications. What medications the patient takes. P is pertinent past medical history. If the patient is having chest pain, I honestly don't care about the fact he fractured his ankle 45 years ago. All right. I want to know more about what's going on now and the pertinent past medical history, like diabetes, stents, previous MIs, cholesterol, hypertension, things like that, thyroid issues. Those are all important things I want to find out on the past medical history. Last oral intake, what did they have to eat or drink? And when was the last time they had it? Events leading up to the illness or injury, what were they doing when it happened? Well, I was outside mowing the lawn and I started developing chest pain. I came back inside and it's just not going away. All right. So we were outside mowing the lawn. It's 100 degrees outside. And the pain won't go away. The doctor told me I should start taking these nitros, and I'm not sure what they really do, but I've taken 6 of them already and it's not helping. Oh, well, in that case, let's take a look at your blood pressure really quick. So other thing as far as critical thinking in the assessment here is gathering. This is your seeking facts. This is the part where I start asking about the interrogation that we do, because we need to ask them important questions to get important answers to work at our differentials, right? So we look at our differential diagnosis. If I say the patient's having chest pain, okay, well, what kind of pain is it? Because sharp pain in the center of the chest with shortness of breath could also potentially be a pulmonary embolus. So we're going to do some other things to rule that out, right? As part of our differential. So if everybody go ahead and this is something else too, something called Levine sign. Everybody ever heard of Levine sign before?
No.
So Levine sign is go ahead and take your hand and put it over your chest with your fingers spread open. Okay. Now go ahead and squeeze. Like squeeze, make a fist. Okay. That's Levine sign. So one of the things they say with Levine sign would be is if the patient is squeezing their chest, it's most likely going to be a cardiac event. If it's open hand across the chest, it's most likely to be something more intramuscular type deal. Again, not definitive. Don't always go by that. But if you walk in with someone squeezing their chest, hunched over, who's pale, cool, clammy, and diaphoretic, who's crushing chest pain, I'm thinking cardiac at this point in time, and unless I can rule it out. This patient gets an immediate 12 lead, and all 12 leads, EMT and up, should be done within the first 10 minutes of patient contact, right? So gathering, seeking facts, asking the questions, and looking at everything that's going on, right? You've got to be observant. You have to ask those questions you need answers to, right? If anybody's ever really worked a call with me before, and I don't think anybody here really has, I'm very persistent on getting information on a patient. Why? Because I want to be that professional jerk, if you want to call it. I want to be professional in the language I'm using here, but I want to be that professional guy that's going to get that information from that patient. I need to know everything about them to come up with a differential to treat them, right? And if they withhold something, or if I don't ask the appropriate question, and the higher up you go in your level of care, I could give a medication that could kill somebody because I didn't know more about their history, right? Again, not going to get into stuff, but there's cardiac things that we can give medications to, that if we give the wrong med, it could actually do more damage than good. And really quick, I know we got to get moving on this really quick. One of them is a patient that's in rapid atrial fibrillation. We want to give them something called diltiazem, and they have Wolff-Parkinson's White syndrome, and they didn't tell us. And we didn't pick up on delta waves on an EKG. More than what you guys need to know, but that will do more damage to that patient than good. Right? So we have to know more about our patients. We have to ask questions. Very important. Evaluating, considering what the information actually means. Right? I can tell you, working down in the South, I've had to change my way of asking questions, and I'm sure Zach can probably attest to that. It's not the same as of evaluating a patient up north. Their terminology down there with the patients are a lot different. So I'm sure Zach can probably go more in detail on the assessments in the South, but I had to learn it, and it was something that was different for me as far as how the patients responded back to certain questions that I asked.
And I kind of echo Kevin there, is know your audience. And, it's something that you hear kind of in the business world, but even in medicine, if you walk in and start throwing out crazy long words and definitions and medications, you may skip things. For example, locally for me, if you go to someone and ask what kind of medical, you say, what's your medical history? They say, I don't have any. Well, the reason they say don't have any is because they've been treated for it. So then you say, well, what are you taking medicine for? And they'll give you about 30 different things that they're taking medicine for. So it's just knowing your area, knowing your people, and kind of learning how to decipher, but extract that information. It really is an interrogation. You really have to get to the bottom of it. And these people are not trained like you are to learn that information.
And everywhere we go is different. I learned what I have: the high blood is blood pressure, is hypertension. The sugars are diabetes. I got the sugars. Okay, you have diabetes. Got it. High blood sugar. Okay. So there are a lot of different terminology out there. And I'm sure Morgan is seeing some things up in Berlin too that are different from down here in the Ospey Valley that I'm working in right now. You got to, like Zach said, you have to know your clientele. Who are you dealing with? Synthesizing, putting the information together to plan a scene management and patient care. We are looking at a reverse pyramid. So I wish I could. If I can get this to actually work, I'll show you. So if I did this here, I drew a line across and down and back up again. Okay. All the things up here, my little lines, so I can't really draw with my pen very well. These are all the things that potentially could be. Down here is your diagnosis that you do in the field. And all this are tests that we perform. Differential diagnosis utilizing the reverse pyramid effect, right? Assessment. All the potentials, all the tests that we put in here, blood pressure, EKG, blood sugar, vital signs, questioning, sample history, all OPQRST, all that leads to this. And usually we do this in about 3 minutes. That's a minute, right? That's how fast we do differential diagnosis. And that's what we're looking for, right? Getting all this information and putting it into a plan, but we can't do a plan until we have a diagnosis. Now, they'll say, EMTs and paramedics, we don't diagnose. We're giving medications to a patient just like a physician does. We have to have some formulated plan of a diagnosis. And that's what we're doing. Any questions on that at all? Everybody good? My chat is working now on my phone, so if you guys want to chat in, you can too. But
Kevin,
everybody,
so the top of your triangle, that's like the signs and symptoms, like when we're asking the questions and then we're going into the test and then we're getting the diagnosis?
correct. Yeah. So
Okay.
these are what a potential altered mental status could be a couple of things. ETOH, diabetes, stroke, MI. I mean, that's what we, oh, wrong button. Not
So
so much
all the possibilities.
correct. These are all up here are all your possibilities it could be.
Got it.
These are all the questions and tests you're going to do. And this is what we come in as we call a working diagnosis. And it usually takes us about 3 minutes to make that happen. 3 to 5 minutes. Right? That's called being a clinician. That's differential diagnosis. You ever watch a TV show House?
Yeah.
Everybody lies, right? So with that being said, though, he does differentials in the show at a very higher level. We're bringing it down to pre-hospital medicine, right? And that's what I call what do we do in the field? We practice medicine, right? We have a license to practice medicine. And if we're using medicine, we have to have differentials, right? So let's do our differential diagnosis. Any other questions at all with that? This is why I have so much fun teaching patient assessment. There's a lot of cool things we can do. So taking the history on sensitive topics. We already covered this earlier in the lecture, right? Physical abuse or violence, hard to deal with. Report all physical abuse or domestic violence to the appropriate authorities. We are mandated reporters. We have to report this stuff, okay? All right? We're mandated reporters. Follow local protocols and do not ever, 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 ever accuse anybody of doing something wrong. I don't care if you suspect it and all the signs are there of child abuse. Do not approach the parents and say you are an abuser. That is not our place to do that. By also doing that means that they're probably going to throw you out of their house and the kid's not going to be treated appropriately. All right? Play it off as nothing's wrong. Treat the kid. Treat the elder abuse as just as bad, right? Any kind of abuse is bad, right? Do not accuse, involve law enforcement. Let them who have the power to detain and arrest be involved in that situation, not us. Sexual history. We have to know this stuff. This is very important, right? Unexplained abdominal pain in a female patient during childbearing years who is sexually active is unless ruled out as an ectopic pregnancy. Okay, we have to ask about this kind of stuff. Right? Talk about being pregnant, most likely it's ectopic. Right? Especially if they're not getting positive pregnancy tests. Ask the patient at the patient's last menstrual period. You have to know this stuff. It's important to know. And you got that 19-year-old EMT that sometimes they have a hard time asking someone who's in the 30 years old, when was your last period? Right? We have to be adults and ask these appropriate questions. Inquire about urinary symptoms of male patients, right? UTIs, kidney stones, right? We need to know how they're peeing. What color is it? Is there any blood noted? How's the flow been? Right? A lot of important information. When appropriate, ask the patients about their potential for sexually transmitted diseases. Pelvic inflammatory disease in a female is a real thing. Okay? And we have to get to the bottom of it. Also, very deadly if not treated. That's a bad infection that needs to be treated with antibiotics. So we have to know. We have to ask the patient if they've been sexually active and if they have any history of STDs or potentially they could have one. All right? We have to be able to treat it appropriately. Right? If they have, what color is their urine? Is it curdy and yellow? Could it be gonorrhea? Could it be the thing that we got to figure out? Silence. Patience is extremely important. Okay. You need to have patience. You cannot rush people. Again, you don't want to take 5 hours getting a patient assessment either, and a history. Use closed-ended questions that require a simple yes or no. Do you have chest pain? Not when was the last time you had chest pain, because that can go into a whole different story, and they can be talking about that for a while. Consider whether the silence is a clue to the patient's chief complaint. Right? Were they just assaulted? Were they just molested? And they're keeping quiet because you're a male provider. So can we get a female EMT to come in instead with a female patient? So utilize your resources. Overly talkative. Reasons why a patient may be overly talkative. Excessive caffeine consumption. Nervousness. Underlying psychological issues. Like patients that are manic. Ingestion of cocaine, crack, or methamphetamines. Have you ever seen somebody who is high on meth? They are scattered everywhere, right? And one of the things that was really bad for a while, it's not as bad now, was bath salts. I saw some people do some crazy stuff on bath salts. Crazy stuff. When we had that big bath salt craze back in like 2014, things like that. I gave a lot of Versed that year to take patients down. All right. Multiple symptoms. Prioritize the patient's complaints as you would in triage. If the patient's having knee pain and chest pain, I'm going to focus more on the chest pain than I am the knee pain. Right? Look at your symptoms that you have and triage them and start treating them. And start with the most serious and end with the least serious. Like on a trauma patient, if I'm doing a rapid trauma assessment and I notice a fractured pelvis and a fractured tib fib, right? I'm going to stabilize the pelvis and do the tib fib later on down the road. Why? Because the pelvic cavity can hold up to 3,000 milliliters of blood. That is half of your blood supply that can leak into your pelvic cavity that you cannot see. That patient is going to go into decompensated shock very quickly if not treated appropriately, right? So we got to make sure we keep that book closed, right? So you guys remember the pelvis, right? Pelvic girdle, ischium, all that kind of stuff that's there. The symphysis pubis in the middle, in the pubic bone, that's what holds it together. And if that opens up and breaks, fractures there, that's an open book pelvic fracture. There's a lot of major arteries, like the femoral artery that runs through there, but if it is severed, it will cause a significant bleed into the pelvic cavity, causing death quickly, right? So again, we have to make sure we start with our priorities that are high on the list and work our way down. Ankle fractures on a trauma, unless that's all they have, that is not my top priority. It's making sure that the patient can breathe and things like that. Pelvic femur fractures, each femur can hold approximately 750 milliliters of blood on an open femur fracture, even closed, if it severs an artery. Anxiety, Some anxious patients show signs of psychological shock, pallor, diaphoresis, shortness of breath, numbness in the hands and feet, dizziness or lightheadedness, loss of consciousness. Panic attacks make people feel like they're having heart attacks, right? So don't go down the whole myocardial infarction route, aspirin, nitro, and all this kind of stuff. If the patient has a history of anxiety, right? Look at differentials and see what it maybe could be. If you have any questions, who can you call?
Medical control.
Medical control. I'm looking to speak with a doctor to have a consultation on what my patient's currently presenting. How would you like me to go about this? Right? I did a 12 lead. The computer interpretation states normal sinus rhythm. Keep in mind, computer interpretation, because you cannot interpret as an EMT. I also transmitted the 12 lead to your facility for you to look at. It appears to be an anxiety attack. Why don't you hold off on giving aspirin and nitro and transport the patient in? That is what the orders may be. Have that consultation because they can also show different signs, right? We'll get more in detail on this stuff later on, though. Anger and hostility. Friends and family or bystanders may direct their anger and rage towards you, right? Cardiac arrest in a bar while their drunk friends around. Why aren't you helping them? Why aren't you saving? Why aren't you transporting them, right? Remain calm, reassuring, be gentle, right? Don't take a patient and toss them off the bed onto the floor if they're in cardiac arrest. Bring them down gently. Please don't smash their head off anything. All right. If the scene is not safe or secured, get it secured. Right. Find people to come in and take over. They'll help with that. Intoxication. Do not put an intoxicated patient in a position where he or she feels threatened. They will try to fight. Potential for violence and physical confrontation is very high with this. All right. Remember, alcohol dulls the patient's senses. Right? They don't really know what's going on. A very nice person can be a complete jerk when intoxicated. Right? But what else could it be if they're ETOH? For altered mental status. Could be diabetic. Right? Any patient who's intoxicated, check a blood sugar. So what happens if you're assessing a patient like this, intoxicated male, female, and they have a fruity breath smell? Any thoughts?
Doesn't that have something to do with their sugar?
It kind of does. But good with that though. So it's what they call diabetic ketoacidosis. And what you're smelling is ketone release in the breath, causing that fruity smell. These patients have blood sugars in the excess of like 250 to 500 or higher. Also very dangerous because they're in an acidotic state, which can kill them. Crying. A patient who cries may be sad, in pain, or emotionally overwhelmed. Remain calm, be patient, reassuring, and confident. Maintain a soft voice. Right? If they've had a loss of a loved one or they're having anxiety because of that, right? Be calm, cool, collective, empathetic, sympathetic. Be there for the patient. TFA is a real thing, psychological first aid. Use it, utilize it, help patients with it, okay? But don't make that your only assessment. You still have to do vital signs and things like that. Depression, among the leading causes of disability and worldwide. Symptoms include sadness, hopelessness, restlessness, irritability, sleeping and eating disorders, and also a decreased energy level. Be a good listener. If you start going into these patients with severe depression, start telling them what's going to happen, they're not going to open up to you. Let them open up to you and let them have that conversation. Be that listener. All right. Confusing behavior or history. So conditions such as hypoxia, stroke, diabetes, trauma, medications, any other drug that could alter a patient's explanation of events. All right, we already talked about that, and we'll go over more about AEIOU tips and things like that later on in altered mental status assessment. Older patients could have dementia, delirium, or Alzheimer's as well. So limited cognitive abilities, also keep your questions simple and limit the use of medical terms. Like Zach was saying, know your clientele, right? Know what's there. And be alert for partial answers and keep asking questions. Rely on the patient's family, caregivers, and friends as well to supply the answers you're looking for. Cultural changes, right? Do not use medical language. Patients may prefer to speak with healthcare providers of the same gender, right? So you want to gain the assistance of the patient's friends and family members to enlist the help of healthcare providers of the same culture or background if possible. There's a lot of different cultures that are out there. I'm not asking you to be familiar with all of them, but it's also very important to have an understanding and ask them about their culture as well, right? They have rights too. Okay, so keep that stuff in mind. Language barriers, there's not so much up here at this point, but what happens if you go to Northern Maine? A lot of French up there, right? French Canadian. You go down to the bigger cities, Spanish, things like that. Portuguese, and things to think about. To find an interpreter if possible. If not, determine the patient understands who you are. Apple and Google Translate do work very well for short things you're looking for. I've used that before in the back of the ambulance working in the Boston area where I don't speak Spanish. It's definitely helped. Keep questions straightforward and brief. Use hand gestures if needed. And be aware of the language diversity in your communities as well. So just know what you're, again, like Zach said before, your demographics. Hearing problems. Ask questions slowly and clearly if they have a hearing problem. Use a stethoscope to function as a hearing aid if need be. Simply learn sign language or learn simple sign language to help with communication. Pencil and paper, dry erase boards in the back of the ambulance, ones that you can utilize, work great. I like dry erase boards as well because you can erase them after. But again, make sure you're documenting what they say before you erase what their responses were. Visual impairments, identify yourself verbally as you enter the scene. It is important that you put any items that you have moved back into their previous position. They have things placed in a certain spot and memorize where they are. So if you start messing around and moving things around, they're not going to be able to find what they're looking for. During the assessment and history taking process, you want to explain each step in the assessment of vital signs. I'm taking your blood pressure. You're going to feel a cuff inflate on your arm. I'm checking your pulse. I'm going to be holding onto your wrist for a moment. I'm checking respirations. I'm going to put my hand on your stomach for a moment, right? I'm going to be taking a listen to your lungs. You're going to feel something cold on your back and on your front side, listening to lung sounds. So explain yourself to them as well and what's happening with the assessment. If the patient is stable on your secondary assessment and has an isolated complaint, you may choose to perform in the secondary assessment at the scene. If the secondary assessment is not performed at the scene, it is performed in the back of the ambulance en route to the hospital. However, there will be situations where you will have, or you may not have, excuse me, time to perform the secondary assessment. Like if you're stuck on airway or breathing or a significant trauma patient where you can't go back over the secondary assessment because you're stabilizing this patient at this point in time for the transport. You may have to continue to manage life threats identified during the primary assessment en route to the hospital. Second. The purpose is to perform the systematic physical examination of the patient. All right, we do our same thing every single time. For adults, we do a head-to-toe assessment. For pediatrics, we always start at the toe, work right to the head to kind of gain their trust. All right. In the assessment of a focus on certain age area or certain area or systems of the body, often determined through the chief complaint or a focus assessment. All right. So what we're doing, like how do we assess this? We look at three things. We inspect, we palpate, we auscultate. Right. So for inspection, we're going to look at the patients for abnormalities. Look at everything. Okay. Touch and feel the patient for abnormalities. You have to touch your patients and palpate. Be professional. If you're dealing with a female and they have large breasts, please do not use your hand and grope them to pick them up to assess underneath the rib cage. Use the backside of your hand and professionally lift them out of the way, especially when we're placing 12 leads. It's very important where electrodes go on a 12 lead for a patient. And if they have bigger breasts and you have to go down lower, you're missing the fifth intercostal space, the important parts of how it truly reads a 12 lead. So again, professional, lift it out of the way, place your electrodes, and keep the patient's decency and dignity in place. Auscultate, listen to the sounds a body makes by using a stethoscope, lung sounds, heart sounds, abdominal sounds, things like that. Use the mnemonic DCAP BTLS or DCAP Beatles, another name for it, and you're going to compare the findings on one side of the body with the other side when possible. DCAP BTLS stands for deformities, contusions, abrasions, punctures and penetrations, burns, tenderness, lacerations, and swelling. Systematically assess the patient on the secondary assessment. So the goal is to identify hidden injuries or identify causes missed during the 60 to 90-second exam during a primary assessment. So on Sunday, Morgan and Scott will be at the hospital with you guys going over the assessments. Okay. I will try my best to get up there that day. October 1st, we will also be doing assessments after noontime, after lunch until 5. We will be doing a lot of hands-on assessments and vital signs, things like that, taking blood pressures and all that. So really what they're going to cover on the first day is how to check a blood pressure, how to check a pulse, how to do pupillary response, how to check lung sounds. Going over all that and incorporating the primary and your rapid assessment into that. Then we'll go more in detail later on in the next class. For a focused assessment, we're going to perform on patients who have sustained non-significant mechanism of injury or on non-responsive medical patients. This is typically based on the chief complaint. So your goal is to focus attention to the body part or system affected by the priority problems. So what they're saying here is if you respond to a patient who fell and all they're complaining of is knee pain after your rapid, focus on the knee. All right. You don't have to do a head to toe detailed again after that because they're alert oriented. They can tell you what's going on. If they're unconscious, then there's really no focused assessment. Right. All right. So any questions to this point? Everybody good so far? I know it's a lot we're going over. All good?
Yep.
All right.
Yep.
Perfect. So respiratory system. You have to expose the patient's chest. You have to take a look at it. Right. Look for signs of airway obstruction. Stridor being one of them. Right. That high-pitched sound in their voice. Inspect for symmetry. Equal rise and fall. That's what we're looking for. Equal rise and fall. Take your hands, put it across their chests, around the rib cages, open your fingers up wide open, go underneath the breasts and lift up a little bit and wrap around that rib cage and make sure they can breathe in and exhale. Inhale, exhale. Your hands need to move up and down at the same time, looking for that symmetry. Listening to breath sounds. So Morgan will go over lung sounds with you guys on Sunday, more in depth. On the 8 different locations on the back, we're going to be checking, and the 6 different locations on the front, listening to a very good set of lung sounds. In the meantime, the practice, right? Every one of you guys should have your own stethoscope. If you don't have one, if you're going to be an EMT, you should go out and buy a good one, okay? Now, they range up to $500 from like $10, right? buy a good one. If this is a field you want to get into, buy a good stethoscope. All right. So again, mine costs about $400, but but I do a lot of stuff with my stethoscope. Right. But invest in the money. This is your career you're going to get into. Invest in something that's good. Lippmann makes phenomenal stethoscopes. Take that stethoscope that you have, go to your computer, go to YouTube, and type in lung sounds. Turn the speaker volume down low, place the bell of the stethoscope over the speaker, and listen. Right? You can play lung sounds all day long through your speakers and hear them. It sounds different through a stethoscope. So put your stethoscope in your ears, place it over your speaker, and give it a shot. And listen to rales, rhonchi, fluids, pneumonia, things like that. Just type in pneumonia lung sounds. Stridor, congestive heart failure, pulmonary edema, right? Type in different things and listen to them. Get good with them. Practice, right? Listen to the breath sounds. Measure the respiratory rate. How many times are they breathing in a minute? Normal ranges. Adult is 12 to 20 breaths a minute. Right? A child is 15 to 30, and a pediatric is 25 to 50. Those are your normal ranges for respiratory rates for those different age groups. Look for retractions and increased worker breathing. Okay. Rate, rhythm, quality. Rate, rhythm, quality. Memorize those three words. You do the same thing for heart as you do for lungs. Your pulse rate, rhythm, and quality. Lung sounds. And here's again. So children breathe faster, even faster rates. We already covered those rates with you already. Count the number of breaths in 30 seconds, multiply by 2. Your respiratory rhythm, regular, is a time from one peak chest rise to the next is fairly consistent. Irregular, the respirations vary from the rate and changes as well. All right. 1 second here. All right. Quality of breathing. So normal breathing is silent. Okay. You shouldn't be able to hear normal breathing. Right. Breathing accompanied by other sounds may indicate a significant respiratory problem. So that gurgling, the crowing sound, the seal bark for kids with croup, right? Those, if you hear a sound like that, then something's abnormal. We got to decipher what that may be. The depth of breathing is the amount of air the patient exchanges, depends on the rate and tidal volume as well. Again, we'll go over more in depth and tidal volume in the respiratory section of assessment. Breath sounds. You can almost always hear breath sounds better on the patient's back. People that listen to lung sounds in the front are not getting a thorough assessment of lungs. Lung sounds. It just tells you moving air in and out really quickly, right? So front and back, as you can see here, right? What we try to do is up here, then over here. So I'll kind of draw a line here to here, down to here, over, down, over, then over here on the side, and then the other side over here. All right, in the front, we start here, go over, go down here, and over, and down on more on the sides and the lower parts of the lungs. Okay. So 6 in the front, 8 on the back. Any questions on that at all? Again, when we're in person, we can actually show you a little more in depth, but I'm trying to draw it the best I can with the pen that I have. So what are you listening for? Normal breath sounds, snoring breath sounds, anything that has to do with snoring. Could be some kind of airway obstruction like the tongue, wheezing, or bronchoconstriction, crackles, or that fluid. Could be something like a CHF, bronchi, more of like a pneumonia. It's more like an infection. A lot of times you'll hear bronchi more on one side than clear on the other. That kind of goes more like lobe specific pneumonia. And then we have stridor, which is going to be upper airway more, right? So if I drew a head here, this would be absolutely horrible because I draw stick figures. Oh my goodness. Okay, here's my little arms. He's all happy, right? Right, our lungs are sitting up here in the chest here. Upper airway, stridor, be more located up in this area by the pharynx, up higher, okay? And that located the pharynx area. I know it's a horrible picture. Go with it. Wish I had a picture of a lung on here. I could show you a little bit better where it would be, especially even like an x-ray or something. So look for trauma to the chest and listen for breath sounds, right? You want to consider for cardiovascular. Consider pulse, respiratory rate, and blood pressure as well, and pay attention to rate, rhythm, and quality. Those three words are coming back to haunt you again. Rate, rhythm, quality. Rate, rhythm, quality. Right, we got all three of those on the cardiovascular system. Consider your findings when assessing the skin: pale, clammy, diaphoresis. Check for compared distal pulses. All right, radials. If you want to go down to the feet, you can check that too. Make sure you're circulating. If you do not have good cap refill, you do not have good dorsal pedal tibial pulses, then we're not getting enough circulation to the lower part of the extremity. All right. Consider auscultation of abnormal heart sounds as well. These are your pulse rates. I would memorize these if I were you. Write them down, take note. You're going to see these again. All right. The normal rate for an adult is 60 to 100. Anything less than 60 is considered bradycardia. Anything higher than 100 is considered tachycardia. Anything between the middle is considered normal. All right. The younger the patient, the faster the pulse. All right. The big ones to memorize, okay, are going to be your infants here. All right. And then memorize your adult. Right. But you want to look at your infant and then obviously your oh, wrong button. These ones here, like the 85 to 205, your infants up to 3 months of age, more like your neonates and up. And when we get into resuscitation later, neonatal resuscitation is different in New Hampshire and Maine versus our normal CPR class that teaches us CPR. Okay, so we'll cover that on October 1st when we do our CPR lecture. Pulse quality describes a stronger than normal pulse as bounding. A pulse that is weak or difficult to find or feel is considered as weak or thready pulses. So thready or weak is like you barely can feel them, to a bounding pulse. Bounding pulses are bad. We don't want to feel anything bounding because bounding would indicate very high blood pressure as well. So we got to make sure we keep an eye on that. Pulse rhythm would be regular. The intervals between each contraction should be the same. So your ventricles should be firing at the same time in unison, like boom, 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 in that order, right? A pulse should occur at the constant regular rhythm. Now, if the patient's irregular, if the heart periodically has an early or late beat, or if a pulse beat is missed, that's going to be a patient that potentially could be in atrial fibrillation, right? Patients that are in atrial fibrillation, as a side note, usually are on some type of blood thinner as well, because the heart is not pumping effectively, causing blood to kind of sit still, and they can start clotting. So they put them on blood thinners. Blood pressure is the pressure of circulating blood against the walls of the arteries. So a drop in blood pressure may indicate a loss of blood or fluid components. Again, fluid components being diarrhea, vomiting. So a loss of vascular tone and sufficient arterial constriction, or a cardiac pumping problem. All right. So hypovolemia, cardiogenic shock, heart attacks, STEMIs, things like that. Okay. Loss of vascular tone and arterial constriction, right? Anaphylaxis can also cause part of that as well. Decreased blood pressure is a late sign of shock, right? We don't want to have that happen. So we're looking more at decompensated. Once they hit irreversible shock, the patient is going to die. So we want to make sure we keep them away from that. Abnormally high blood pressure may also result in a rupture or other critical damage in the arterial system as well, right? Then remember about hypertension is, I can't write it down there, but it's stroke. All right. Hypertension can cause stroke in a patient. Okay. So keep that stuff in mind as well. So a blood pressure cuff with a gauge contains the following components: a wide outer cuff, an inflatable wide bladder inside of it, a ball pump with a one-way valve, and a pressure gauge. Another name for that is a sphygmomanometer, is another name for the blood pressure cuff. All right, those are the things that we're going to have with that. So auscultation is the most common means of getting a blood pressure, okay, by utilizing your stethoscope. Please do not do things by palpation unless you absolutely have to, right? Palpation only gives you a systolic, where auscultation gives you a systolic and diastolic, which is what you want to know. Remember that systolic is pressure in the arteries, right? Versus no pressure in the arteries is your diastolic. You kind of keep that very simple, all right? Your arteries are either under pressure or at rest, right? When your diastolic pressure is like greater than 90 or greater than 110, the problem with that is now even at rest, they have a high pressure underneath there and can cause for vessels to blow, like in your head. So normal blood pressure would be hypotension, which would be blood pressure lower than normal. For hypertension, blood pressure is higher than normal. So as you can see, looking at these different ranges, 90 to 120 is your normal range. These are based off your systolic blood pressure, right? 110 to 130, 97 to 115, working your way down the neonates. Down here, very bottom, 67 to 84. So I'm not saying memorize all these, but understand, kind of put them in like small ranges. Like, figure 86 to 106. This could be like 90 to 110, things like that. Just try to memorize the ranges based on neonate versus adult, what a child would be. We don't do a lot of neonatal blood pressures anyways. So. All right. Neurological assessments should be performed with any patient who has a change in mental status, a possible head injury, a patient is stupor, dizziness or drowsiness, or syncope. We're going to evaluate the level of consciousness and orientation. We're going to use the AVPU scale if appropriate, and we're going to talk about that GCS score again as well. All right, it is 9 o'clock. Let's just take 5 minutes, and then we'll finish up here. We're very close to being done. So let's just take 5. We'll come back at, let's just say 9:15. A little more than 4 or 5 minutes. All right, everybody back? Gonna finish up and get to the review questions here.
I'm ready.
All right, let's make this happen.
Here.
Perfect. All right, up to this point though, how are we doing? I know that was a lot of information so far. Everybody okay?
It's a lot, but you know,
Am I explaining it enough in detail for you guys to understand?
oh yeah. I mean, at least for me, but it's still a lot.
Yeah, you're
It
explaining
is.
it good. Can you be there for the test day though, so I can lean on you for questions?
Do the best I can.
All right, Kev. Are you in New Hampshire? You said, yeah.
Yeah.
Are you listening to the pager at all? Did you hear the
No,
last?
what is it for? I heard
A
AT to sign off.
77-year-old woman intentionally drinking bleach for self-harm.
Yeah, that's not good.
No.
Well, we can use a lot of these calls later.
Yeah, a lot of
Yeah.
questions come into mind, like, is she really intentionally drinking it, or someone making her drink it? Like,
Yeah, you know, things to think
like
about.
who called in and who's there? Is the scene safe? Probably not.
Bleach is very, very bad. All right, let's talk about pupils though. Let's talk about pupils, and then we'll get to our review stuff, and then we'll get out of here by hopefully before 10. So pupils are the black center portion of the eye, the black part of the eye that we see. Normally round and approximately equal size. The size we normally see is right around 4 millimeters. That's normal. Okay. So in the absence of any light, the pupils will become fully relaxed and dilated. All right.
Kevin, are you not talking or is there something wrong?
Oh, I'm back.
Oh, all right.
I don't know how I got muted. That was weird. All right. So why are pupils important? Why was it important to assess pupillary response?
Well, I can tell you a lot of things. Are they on drugs? Are they having a stroke? Are they
Okay.
a brain injury?
Perfect. I love it. This is all good stuff. So we have restricted pinpoint pupils, dilated, and unequal.
Might be on mute again.
Why does it keep muting itself? I don't get it. That's weird. I'm not even hitting the button over there for mute at all. Let's try this. All right. So let me go back to here. So a small number of the population exhibit unequal pupil. This is what they call anoscoria. You have one large and one small, and they're born that way. So causes of depressed brain function would be injury to the brain or brain stem, trauma or stroke, brain tumors, drugs or toxins, inadequate oxygenation or perfusion. So we'll see some changes with that. Pearl, Pearl, is a useful assessment guide. Pupils equal and round, regular in size, and react to light. I use Perla, so Perrla. Pupils equal, round, and reactive to light and accommodation. So it depends on which one you learn, and how you want to pursue it. But as long as they're Pearl, Perla, Perl, whatever you want to do, but as long as they're equal, round, and reactive, regular in size. That's the important part. So we're going to check for bilateral muscle strength or neurovascular status. So we're going to check bilateral muscle strength and weakness and complete a thorough sensory assessment and test for pain, sensation, and position. All right. This is on Skill Drill 10.5. You look in your ebooks. Compare the distal and proximal sensory and motor responses to one side with the other, right? So with that being said, it's what they call CSM, sensory motor my goodness, circulation, sensory motor, pulse, grips, things like that, and equal in movement, motor response. We're going to use CSMs in our neuro assessments. Yeah, we'll go more over that in detail. We talk about mental status changes and things like that. Anatomic regions would be more of the head, neck, and cervical spine. So we're going to palpate the scalp and the skull. Use your fingers, both hands, palpating the head, the skull, checking the patient's eyes, looking for pupillary response, palpating around the orbits, see if there's any fractures. We're also looking for raccoon eyes. Raccoon eyes would be orbital fracture that you would find. Check the color of the sclera, right? The white part of the eye. If it's yellow, that means they're jaundice, which would indicate liver issues as well. We're going to assess the patient's cheekbones, right? So go right down through zygomatic bones, maxilla, mandible. Get used to saying these terminologies of the human body with the bones. And check the patient's ears and nose for fluid. Two things we're looking for: the fluid of the ears coming out. If it's clear and you take it onto a 4x4 or 2x2 and it has a yellow ring around it, that's what they call the halo effect, right? Which would be an indication of cerebral spinal fluid coming out of your ears. Okay. The other thing we're looking for is something called battle signs. What are battle signs? Any ideas?
Bruising?
Correct. Bruising, which should be indicative of a specific fracture. So the basilar skull, right? So why is that important for us to know, right? Basilar skull fractures are a contraindication on putting in a nasopharyngeal airway, right? So if you have battle signs and you put a nasopharyngeal airway in and you have a basilar skull fracture, the nasopharyngeal airway can go into the skull versus into the nasal passage, right? That's why you need to know what basilar skull fractures look like, looking for those battle signs, right? Check the upper maxilla or maxillae in the lower mandible of the jaw. Open the patient's mouth and look for any broken or missing teeth and note any unusual odors in the mouth. Okay. We're going to inspect the chest, looking at inspection, visualization, and palpating the chest, looking for symmetry. Look for both sides of the chest to rise and fall together with normal breathing and observe any abnormal breathing signs. We'll go over respiratory patterns later. The abdomen, we're going to palpate all four quadrants for tenderness, rigidity, patient guarding, rebound tenderness, looking at all the different quadrants, right and left, upper and lower. You have to know as an EMT and moving your way up in the ranks where all the major organs are located. So as you're palpating, you know what you're feeling for. So spleen, kidneys, liver, large intestines, small intestines, appendix, pancreas, right? Gallbladder. Where are all these things located when you start having these pains? So understand where those things are located. Ovaries for females. Pelvis, expect for symmetry and any obvious signs of injury, bleeding, or deformities, right? Looking for that open book fracture, that deformity, that unstable pelvis. Extremities, looking at decap BTLS, right? Looking and palpating for deformities, checking for pulse and motor and sensory functions to make sure things are moving appropriately and we have good neurofunction in the extremities. Looking at the posterior body, inspecting for decap BTLS, symmetry, and open wounds. Palpate the spine from the neck to the pelvis for tenderness and deformity. Who can tell me how many cervical vertebrae there are there?
33.
33 total. How many are in the cervical?
7.
All right, thoracic.
13?
12.
12.
Yep, no worries. All right. Lumbar.
13.
The lumbar has 5. All
I
right.
was trying to do
tall
the math.
person.
No,
I was doing the
sacral.
math, and I was like,
What about the sacral?
7.
5. 5. right? And the coccyx.
4.
What's so special about the lumbar?
That's what.
What's different about the lumbar versus the thoracic, other than number of vertebrae? They're fused together as one plate. Okay, so very important to know these as you're palpating down, looking for any kind of step offs from the spinous processes that are there. All right, pulse oximetry. And this one here, again, it's a tool, but don't make it your ultimate diagnostic tool to treat. All right, use appropriate devices. They should never replace your comprehensive assessment of a patient. Right? What are 2 things that can cause a false reading for a pulse oximeter reading?
Nail polish.
Nail polish will throw it off. What are 2 conditions or that a patient could have?
The cold hand thing that somebody says they
Raynard,
have.
for cold hands would give it false readings. Yep. Carbon monoxide poisoning in patients that are anemic. Okay. Patients that have carbon monoxide poisoning or anemia will still show a pulse ox reading of 100%, even though they're not oxygenating appropriately. Because, and I'm not going to get into the chemistry behind it because it's not. It'll take another 2 hours to explain everything. But
So that thing works with light. That's how it detects with light.
it does. Yeah.
It does.
Yep. All right. Measures oxygen saturation in the hemoglobin in the capillary beds. That's all it's doing. Patients with difficulty breathing should receive oxygen regardless of their pulse oximeter value. Okay. Give them O2. Nasal cannula, non-rebreather, whatever has to happen. Nasal cannulas actually work pretty well on these patients. We'll go over more of that in detail later. Capnography is a quickly provide information on a patient's patient's ventilation, circulation, and metabolism. We will go more in detail on capnography as that is now a BLS skill in New Hampshire. All right. There's a BLS skill in New Hampshire to put on nasal capnography and learn how to read the waveform that's there. It is not taught in this lecture for some reason, but I have my own that we can do. All right. Blood glucose, measuring the blood glucose in the bloodstream. There is a difference from venous blood and capillary blood. We are checking blood glucoses with capillary. All right. I see a lot of providers that do it with IV sticks, and it's just that's venous blood. Non-invasive blood pressures, we'll go over that more in detail on Sunday. All right, and to finish up with reassessment, we're almost done. Perform at a regular interval during the assessment process. Repeat the primary assessment and reassess vital signs. Look for trends and compare baseline set with other sets you've done during your primary assessment, everything else. Kind of look for that baseline, that trending that you're looking for. Is it getting better or worse? Right? Stable patients, vital signs every 15 minutes. You will see this on a test. Stable patients, 15 minutes. Unstable patients, 5 minutes. Right? As far as reassessment of vitals. Reassess the chief complaint. Answer the following questions. Is the current treatment improving the patient's condition? What have you done to make that treatment? Has an already identified problem gotten better? Or has an already identified problem gotten worse? And what is the nature of any newly identified issues? Right? Pick up on your reassessments. If you give a medication, reassess it after 5 minutes and see if you're making a difference. Recheck all your interventions. Right? If you put someone on a splint, you need to check CSM's pre and post splinting. By the way, that's a critical fail if you don't on your national registry skill stations. Most important are the ABCs. Make sure the patient's still breathing, has a patent airway, has good circulation. Ensure management of bleeding and ensure adequacy of the interventions and consider the need for new interventions after that. The one thing you guys need to learn, I say the one thing, the multiple things you need to learn, but very important, are cause and effect. What you do to the patient and what the effect is going to be. And you have to make sure you keep reassessing that. Identify and treat changes in the patient's condition. So document any changes, whether positive or negative. Right? If you screwed up, it's okay. Document it. Do not lie about it. All right? Medication errors, report it to your service chief, and you still have to document it in your narrative, right? Reassess the patient, unstable 5, stable 15. All right, before we get to the review, any questions on patient assessment to this point?
Kev, one question with the bleeding. So you cover a wound. Let's say you bandage it, you put a 4x4, whatever it is. Is it proper not to take that off and just reapply? If let's say it starts soaking through, and
Yep.
reapply over the current and not take off. Correct.
Correct.
Okay.
So 4x4s and 2x2s, 5x9s, abdominal pads. You notice how they have like a cross thread that are in there? Okay. That is designed to collect and catch platelets to start clotting process. So if you pull that off, you start all over again with a whole new clotting process again. So keep putting it on top and on top and on top and on top, right? Until we get the bleeding controlled, right? Did that answer your question, Fred? All right. Anybody else have any other questions at all? All right. With silence, we'll continue on with the review. During the scene size up, you should routinely determine all the following except. And you can put them in your chat box. I do have them. It's up and running. All right, everybody's putting down B. The answer is B. You arrive at the scene of an injured person. As you exit the ambulance, you see a man lying on the front porch of his house. He appears to have been shot in the head and is lying in a pool of blood. You should do what?
Retreat to D.
Scene
Okay.
safety.
Scene safety. I'm seeing a lot of D's pop up, and D is correct. Findings such as inadequate breathing or an altered level of consciousness should be identified in the what part of what assessment?
Primary.
Okay. I'm seeing A pop up in here too. Yep, primary assessment. Good. Number 4, which of the following would you not detect while determining your initial general impression of a patient? All right, D, heart rate. General impression does not have you doing a pulse roll at the bats, ABCs. Your primary assessment of an elderly woman who fell reveals an altered level of consciousness and a large hematoma to her forehead. After protecting her spine, you administer oxygen. And administering oxygen, you should do what after that?
B.
So I'm seeing B's and D's.
B's.
Yeah, I see B and I have D's popping up here as well. The answer is B. Okay, so let's go back for a second. Right? Because she is altered, we have to perform a rapid exam before we get to a focused assessment. Right? We're going to do a rapid trauma assessment to see if there's any other injuries that we might note. Injury life threats. Number 6, a semi-conscious patient pushes your hand away when you pinch his earlobe. You should describe his level of consciousness as, this is your AVPU scale.
C.
Yep, C it is. Painful response. Number 7, assessment of an unconscious patient's breathing begins by
C.
we have an unconscious patient. The answer is B. We're going to position the head first, whether it be jaw thrust or head tilt chin lift.
Oh, God damn it.
That's okay. Your 12-year-old patient can speak only 2 to 3 words without pausing to take a breath. He has a serious breathing problem known as, and I know I covered this one here multiple
B.
times.
I'll never forget this.
Never forget it. I went over it like 15 times today.
Yeah, B.
B it is. Number 9. How would you determine the pulse in an unresponsive 8-year-old patient?
D.
Yeah, D it is. Unresponsive patients older than 1-year-old, carotid pulse. Can't feel it, start CPR. Last one. So when assessing your patient's pain, he says it started in his chest, but has spread to his legs. This is an example of what part of the OPQRST?
C.
C it is, radiation of pain. Perfect. Let me just turn off the recordings here.